time about your cases that you've done in the past. So people really
Thank
enjoy it
you.
all around.
So thank you so
Okay.
much. And this time, again, like we discussed, we have some interesting cases for you. And I welcome you all to this telecast once again.
Yeah.
So our day will have, variety of endoscopic
So Dr.
surgeries
Satish, they
today.
haven't gone live yet, so they will go live in a few minutes. So can I have a
So
chat?
Dinesh,
Okay.
has he gone live? Let me. We're live,
Okay.
Dinesh. So I welcome, yeah, Dr. Rokade.
Okay. Perfect.
Yeah.
So good morning and welcome to colleagues from around the world. This is our uh, third and the final day of live surgical event. We started on Monday with Prof. Paulo Castanova and with Prof. Manuel Bernal Speckelson from Spain. And then we joined Columbus, Ohio. And yesterday we also had a great surgeries from the centers with Professor Richard Harvey in Sydney, Australia. And today we're looking forward to this grand finale. So we have very interesting cases lined up. We have with us Dr. Satish Jain from Jaipur, India. He hardly needs any
पूरा टीवी
introduction.
का वॉल्यूम
He has
मैक्सिमम
been
कर
a very integral part of GRN events, live surgeries, and they have always been very, very popular. So we will have some very complex sinus surgical cases lined up, almost testing the limits of sinus surgery, so as to say. So interesting day lies ahead. I have with me my colleague Louise Melia. So good morning, Louise. And
Good morning, Ashok.
so Louise is from Bath in the UK. She's a radiologist and a skull-based surgeon. So we will go over to Jaipur to join Dr. Jain.
Thank you. Thank you, Dr. Rokade, for this opportunity once again. And I welcome you all to this telecast from the Pink City of Jaipur. I remember, and I'm so grateful to Dr. Rokade for involving me in his academic programs, which are very popular to spread academics all over, particularly in the Western world. I have some fond memories of the previous telecast wherein we had a lot of interaction during live surgical session. So once again, thank you very much for giving me this opportunity and involving me here. Today, we have lined up variety of endoscopic cases. We will, of course, begin with a young child having JNA, extensive JNA with all possible extensions, and we'll go endoscopic with discussion on indications and all those things. Then we have some endoscopic interesting cases like adenoidectomy with coagulator and microdebrider. We have some primary sinus surgery. We have some focus on frontal sinus surgery. Then we have cases of revision sinus surgery, and then interesting CSF rhinorrhea with meningo and cephalocele. So probably we'll go till 3 p.m. India time or maybe beyond, depending upon the, what Dr. Rokade directs me. So today I am all over to him for his, this academic event. And thank you once again. And can we go ahead with the CT pictures or the imaging?
Yeah, please do.
So, Dr. Rokade, I would love to be interrupted again and again for any questions from the audience to make it more and more
Sure.
interactive. Believe me, this is again a good learning opportunity for me as well with this interaction. So I welcome Dr. Lewis for this wonderful day for the interaction, and I'm very sure that will be definitely everybody will be benefited with this kind of interaction. So this first case, as I discussed, as I told you, is a young child, is a 12-year-old child with a nasal blockage. On endoscopy is a mass in the nasal cavity and nasopharynx. And then, in a 12-year-old child with such kind of a mass lesion with history of, repeated bleeding is always something which goes in favor of JNA until proved otherwise. Now, JNA being a vascular tumor, it has a propensity to bleed, we all know. So we never, advise biopsy for such lesions to prevent hemorrhage. So our diagnosis is further established by imaging. Now, there are lots of controversies regarding what kind of imaging to be ordered. So here we have an imaging protocol with discussion on pros and cons of kinds of imaging. So the first imaging what I'm showing is a non-contrast CT scan. Are you getting CT on the picture on the screen?
Yeah, yes,
Yes.
we are.
Yeah, so this is a non-contrast CT scan. See this in the DICOM format. If I show the coronal one, what you get on this non-contrast CT scan is a mass lesion in the nasal cavity going, see this broadening the sphenopalatine foramen going out, but you cannot differentiate what kind of lesion it could be. There are variety of nasal masses from benign to malignant, n number of nasal masses could be, and a non-contrast CT scan cannot actually differentiate between, what kind of a mass lesion it is. So we need a contrast CT scan then. So then let me show you a contrast CT scan. Contrast will give you enhancement. And rather than a plain contrast CT scan, we advise this CT angiogram, which is actually a contrast CT scan with a dedicated angiographic pictures to show you more, to give you more information than a contrast CT scan. So our primary investigation to order when we suspect JNA is a CT angiogram. This gives you enhancement and more information. Let me show you in all three planes what the CT angiogram shows. So in this picture, if you look at the coronal picture, see this. This is the coronal one. If you look at this, see what kind of information it is giving you. This is a enhancing mass lesion which looks like centered at the level of the sphenopalatine foramen and going either side. It is, spreading circumferentially. It is going medial into the nasal cavity, and if you go behind in the nasopharynx, then it has eroded the pterygoid process, then it has eroded the sphenoid floor and, bulging in the sphenoid. It has prolapsed outside through the sphenopalatine foramen, pterygomaxillary fissure into the infratemporal fossa. See, it is going in the infratemporal fossa both inferiorly and superiorly. The most superior part of the infratemporal fossa is involved. Then it is going up. See, this is the greater wing of the sphenoid. This is the greater wing of the sphenoid on either side. And what it is showing, it is eroding the greater wing of the sphenoid and rising up in the temporal lobe of the brain. Though being extradural, see this? And if I show you the sagittal one, you will see better that how it is rising up and going behind and beyond. See this? This is the mass lesion. This is going, see, this is the orbit. This is entering into the inferior orbital fissure. Can you see very clear?
Yes, yeah.
Yes.
Going behind through the superior orbital fissure and then going behind in the cavernous sinus, in the temporal lobe of the brain. It is rising lateral to the cavernous sinus into the temporal lobe of the brain. Now, let me show you on the axial. So, all three planes gives all valuable information. See this, this is the mass lesion. Can you see very clear now?
Yes, yeah.
Yes.
On the axial,
Very extensive.
CT, a contrast CT scan gives you all classical extensions of JNA, and because of these peculiar extensions, the JNA is diagnosed on the basis of radiology rather than on biopsy because it has some preferential extensions. Preferential extension means preferentially it goes in the nasopharynx and the nasal cavity. Preferentially it goes laterally. See, this is anterolateral extensions. Can you see?
Yes. Yes.
And this is by means of eroding the pterygoid, it is going posterolaterally as well. See, both separate extensions, classical. Then see, when you go up, it is going in the inferior orbital fissure. From where it is going behind, and behind, see, this is the foramen lacerum carotid artery. And this is through the superior orbital fissure, it has gone towards the cavernous sinus. It is bulging towards the temporal lobe of the brain. So this is classical extension. The important thing to be noted here is JNA never invades the paranasal sinuses. Of course, it bulges in the paranasal sinuses, but it never involves the mucosa. Never invade the mucosa of the paranasal sinuses. It never invades the cavernous sinus through the paranasal sinuses. We have a general feeling that after involving the sphenoid sinus, it can involve the cavernous sinus. It never goes like that. See, The sphenoid sinus is separate. Can you see the bone? Separate bone of the
Yes.
cavernous sphenoid sinus all around. And this is coming from the inferior orbital fissure, superior orbital fissure. Superior orbital fissure is actually an extension of the cavernous sinus anteriorly. So it has gone from the superior orbital fissure into the cavernous sinus, bulging in the cavernous sinus, and see the carotid artery behind. So it goes circumferentially. And see, this is the bony wall all around the carotid artery. Can you see here?
Yes.
This is the
Yes.
horizontal petrous carotid. This is the foramen lacerum carotid. There's the bony wall. Then this is the cavernous carotid. Now there is no bony wall. And this lesion is particularly, going towards the cavernous, and it can compress the carotid artery. But most of the time it doesn't actually invade. And it progresses towards the cavernous sinus and towards the, superior orbital fissure, cavernous sinus, and this temporal lobe of the brain. It is pushing but not invading the dura. So by means of all these extensions, you can have a fairly good diagnosis of JNA. Now, this being a vascular tumor, you need more information about it. That's why we order, rather than a contrast CT scan, we order a CT angiogram to give you more information about vascularity. See, when it comes to, management of JNA, the first and the most important thing which frightens surgeon is the bleeding. Vascularity is the major concern, and this CT angiogram gives you most valuable information about the vascularity. And what I believe, what I always propagate, we surgeons must know how to read out this CT angiogram to know how the vessels are related to the tumor. See, I need information how we all know the internal maxillary is the principal vessel, primary principal vessel. We should know how the internal maxillary is entering into the tumor so that we can catch it at the right place. How the other vessels are invading into the tumor and supplying, because all these are important for the decision making. If I have a, why this JNA is approached endoscopically most often? Because the internal maxillary comes anterior to the tumor. You can catch the internal maxillary prior to the tumor removal. So you can devascularize the tumor. And that is the biggest reason for the endoscopic, your ability to excise it endoscopically because you take the vascular control before and then remove the tumor. Now, what happens if the vessel comes from behind? If you have extensive vascularity coming from behind the tumor, to me, is the strongest contraindication for a simple endoscopic approach. Either you embolize those vessels primarily to devascularize it, or go by open approach, because otherwise, simply without embolization, you cannot, enter into the tumor, which is too vascular, without taking the vessels in control. So let me show you how to read out the CT angiogram quickly and what is happening in this particular patient. See this, I will show you from below. See, I am starting from the neck. Can you see this carotid artery in the neck?
Yes, yeah, very clearly.
Very clearly. See now, the carotid artery, jugular vein. Now the carotid artery, jugular vein. Now I am going up, up, up. See this, I am going up. And now the carotid is being divided into two. Can you see?
Yes.
Yes.
Yeah, let me show you better picture. See how the carotid being divided into two. Let me show you a better picture. See now, follow my cursor. This is the common carotid artery. Can you see this is the common carotid artery on the right side?
Yes, yeah.
Now I am going up, going up, going up, and this is being divided into two vessels. Is that clear?
Yes, yeah.
Yes.
And
You can
now
the
see there are
division.
lots of branches arising from the external carotid. We know internal carotid doesn't give rise to any branch. So now there are numerous vessels, we all know, all named vessels arising from the external carotid. Right from the first one, this is ascending pharyngeal. Then if I go further, this is thyroid, superior thyroid. Then I go further, lingual and the facial going laterally. If you follow this vessel, this is going See this, I am following this vessel going lateral to the mandible. This is facial artery going back. So further, I am going further. Now the carotid is going behind. Can you see the external carotid turning behind?
Mm-hmm.
Yes.
Yes.
The first branch, the first posterior branch it gives off is occipital. Can you see very clear?
Yes.
Going further, it gives further branch, posterior branch. This is posterior auricular artery. Then going behind the mandible, see this. This is mandible and this is dividing into two terminal branches. Can you see very clear?
Yes.
Yes.
The outer one is superficial temporal and this bigger one is internal maxillary. Now I am going to follow this internal maxillary. See this internal maxillary. See my cursor. Can you see this?
Mm-hmm.
Yes.
Yes.
Gone medial to the mandible and this vessel is going. See this. This vessel is going. This vessel. See my cursor. Where this vessel is going? Anterior to this tumor.
Anterior
This
to
is
the
all
tumor.
tumor. Going anterior here and here into the pterygopalatine fossa. Can you see very clear?
Yes.
Yes.
Now, to ascertain the level of this vessel, wherever this has to be caught in the pterygopalatine fossa, you have to catch at the right place. Let me show you where exactly. This is the basis of, endoscopic excision of JNA. See this vessel, it is going there, it is going in the pterygopalatine fossa. This is how this vessel goes on the normal side. This is this vessel, which is here on the disease side. This is the vessel. If I look at this vessel at the coronal picture, see this. This my vessel is here. And now I am
Yes.
going to follow.
So,
See
yeah.
this vessel is riding up,
Yes.
and this is at this level, it is entering into the pterygopalatine fossa. See this here? So, endoscopically, to catch this vessel in a bigger tumor is a very, very difficult task sometimes. How can you catch? With the CT angiogram, my vessel is here. I can use my, see this? This vessel looks like around 1.8 centimeter above the level of the floor of the maxillary sinus. 1.7 to 1.8. Can you see?
Yes.
This vessel here. So while looking at this vessel, I should have a fairly good idea where to catch this vessel and devascularize this tumor. See, in this surgery, why I am able to take this case endoscopic? From vascularity, the internal maxillary being the principal vessel. My entire goal during surgery is not to enter into the tumor at any point of time without devascularizing it. And that is how we devascularize, we find the internal maxillary at the right place before entering the tumor and catch it and devascularize the tumor to a certain extent. Rest my cobbletter will do. This is the principle of, endoscopic surgery for juvenile nasopharyngeal angiofibromas without embolization. So in our practice, 95 to 98% of the time, we have been able to remove such tumors without embolization. Embolization, of course, is a good strategy to devascularize the tumor, but it has its own pros and cons. The embolizing, intervention radiologist should be very, very expert to prevent dissemination of the agent through the dangerous connection to the internal carotid circulation. Otherwise, it can have its deleterious effects. The cost is another factor. The tumor-related factors are different. So embolization is not always always a good thing, always a welcome thing, I would say. And with this technique, which I am going to show you today, this being such an extensive tumor going intracanally, cavernous sinus, far extensive into the infratemporal fossa, even towards the parapharyngeal space, sphenoid sinus, everywhere we'll be able to remove without embolization and most of the time even without transfusion with this surgical strategy to catch the vessel first. And this CT angiogram is the principal investigation to give you adequate information about the vascularity. Number two, once you deal with the carotid artery, you should have complete information about the cross circulation at the level of the brain. Now see, these are two carotid arteries anteriorly and this is the basilar artery behind. Can you see?
Yes. Yes.
If I look at the cross circulation, see these are giving two posterior cerebral arteries. Can you see? And
Yes.
these carotids are giving two anterior cerebral, making ACOM and the A2. Very clear? This is anterior communicating artery, and this is the posterior communicating artery arising from the posterior cerebral going towards the carotid to complete the circle of Willis. So
Circle of
what I
Willis.
believe, see, this is a cross circulation, adequate cross circulation. To get more information, the DSA is gold standard, digital subsection angiography. But this gives you a fairly good idea that the patient has a, good anterior and posterior communication, good anterior posterior circulation. In case of any, unfortunate situation of arterial injury, still there is adequate circulation to sacrifice the vessel without giving intracranial complications. So DSA will definitely give more information in case your artery is at risk. It is completely encased, giving a lot of arterial disabilities, deformities. Then obviously the DSA is important. In this case, the tumor is approaching the carotid artery but not invading it. Okay. Now, this information to me is still inadequate. I need more information about the diagnosis, about the extensions, about the arterial involvement, about the vascularity from the MRI. So my first MRI would be a T2 weighted MRI, T2 weighted MRI, T2 weighted.
Dr. Satish, at this stage, is it fair to say that it is a very extensive tumor?
Yes,
it has invaded all these possible spaces.
Yes, you can see.
But at the same time, the main vascular supply, which is IMAX, is in a kind of favorable location. It is anterior to the tumor.
Yes.
Okay.
See, it is always anterior. If you look at the, structures into the pterygopalatine fossa, they are displayed in a very, very unique fashion. In the pterygopalatine fossa, the anterior network is formed by the internal maxillary and its branches. And the posterior network is the nerve, the V2 and its branches, the pterygopalatine ganglion and its branches. And this tumor, since arises from behind, from the pterygoid wedge, as it progresses, as it enlarges, it pushes the posterior wall of the maxilla anteriorly. So it pushes all the structures anteriorly, including the vessels. So bigger the tumor, more dehiscent is the wall because of the pressure erosion, and more the vessel is pressed anteriorly. So that's a welcome, sort of thing for the surgeon, as the bigger the tumor pushes the vessel more anteriorly. So you can identify the vessel and, take into control before dealing with the tumor. If without taking the vessel control, if you try to enter into the tumor, this bleeds heavily, and this can show what it is, and one cannot actually handle such kind of tumor endoscopically, because endoscopy requires visualization. With massive bleeding, you cannot maintain the visualization, and then you cannot remove the tumor and completely. The biggest advantage of endoscopy in such situation, it is not about avoiding a scar. That is the least of the important thing. If I enumerate, the biggest advantage of the endoscopy is the visualization it provides. It gives you bright illumination, magnification to the on-site wherever you want. And this tumor, since has a propensity to invade the various crevices, canal, fissures all around at the skull base level, it gives you opportunity to remove this tumor under vision from everywhere, which open approach doesn't. So that is the biggest advantage. The only concern is the bleeding. And if you are able to, take the bleeding in control by means of such surgical strategy, by means of good embolization, still you can remove a lot of tumor. With certain, in our practice, we have certain reservations regarding endoscopic approach. We have certain indications for the open approach, particularly if you have a vessels, when the tumor goes intracranial and it acquires vascularity from the intracranial vessels, then you cannot try to, avulse the tumor down, as it can open up the vessels intracranially and can continue to bleed. This is one of the indications. When the large vessel like carotid is 360 NKs invaded, particularly in revision cases, obviously we avoid the open approach, and then we take a lot of help from the intervention radiologist and go by the open approach, sometimes with neurosurgeon by combined approach, and so many things. So there are indications for such approaches, but most of the time, particularly in primary cases, over 90% to 98% of the situations, we have been able to remove it endoscopically very efficiently, which much better is an outcome. It is the outcome which matters. If some approach gives me better outcome, if open approach gives me better outcome than endoscopy with scar and everything, I still opt the open approach. So it is ultimately the outcome which matters, because this is a benign tumor. Like any other benign tumor, the answer is complete surgical excision. If you leave the tumor behind, it is bound to come back, and we call it as a recurrence. So this so-called recurrence is actually a residual tumor left behind, which grows and become more difficult to remove and more extensive and more challenging. Now see on MRI, T2-weighted MRI, you can see the large flow voids. Can you see? This is the internal maxillary on the lateral aspect of the tumor. This is an internal maxillary. You can see the large, infratemporal fossa component. This is the nasal component. That's the sphenoid component. That's the orbital component, orbital fissure component. And if I follow it, it goes continue behind in the cavernous sinus. See the carotid artery. Can you see very clear? And the tumor
Yes.
enters the cavernous sinus and the temporal lobe from laterally, never through the sphenoid sinus. This is very important because this tumor never ever invades the sinus mucosa. So this is T2-weighted imaging. Now, how can you confirm that this is not a malignant tumor or something else? Why it is, the JNA only? See this. This is what a diffusion-weighted imaging. Can you see this picture?
Yes.
Yes.
Is a very, very important investigation which we always advocate in these patients, and we have a couple of examples to justify it. This is basically a bioimaging. This true bioimaging from MRI. The reason being, it assesses the architecture of the tissue, what you are imaging. So in this diffusion imaging, what you assess is the motion of the water molecules in the magnetic field. So tumor which has more water content will have more diffusion. See this bright diffusion. Tumor which have less water content will show diffusion restriction, will appear dark. See this. What JNA is full of blood. JNA is nothing blood, lake of bloods and the vessels within it. It's nothing but lake of blood, and so it gives good. It is water and water only, and there is no diffusion restriction. And what you can see is the bright. Can you see this brightness? No diffusion restriction. Had
Yes.
this been a malignant tumor, what does a malignant tumor have? Kind of architecture? Malignant tumors have more nuclear cytoplasmic ratio, more cellularity, less water content, and had this been a malignant tumor, this entire what it appearing bright would appear as absolutely dark, and that is a crystal clear, differentiation of a benign from a malignant tumor with high, specificity and sensitivity. I'll give you a couple of examples. Recently, a case was referred to us, 12-year-old child, occasional bleeding, complete nasal blockage, mass in the nasopharynx, CT was done, and diagnosed as a angiofibroma. Came to us looking like JNA, but the endoscopic appearance was not really JNA. So we got MRI done and was a huge diffusion restriction. So we ultimately went in for biopsy and it appeared as a rhabdomyosarcoma. So you have to be very, very careful about the diagnosis, and this diffusion imaging will prevents you from deviating from a true diagnosis. This is really, really helping. And not only JNA, in other head neck tumors, other head neck pathologies, by 95% of the times, you can, with, quite confidence, differentiate the benign from the malignant tumors only by the diffusion imaging. The kind of diffusion restriction the tumor shows gives you a fairly good idea whether it is benign or malignant. Benign tumor have more water content, less nuclear cytoplasmic ratio, and more diffusion. And when the malignant tumor have more and more diffusion restrictions. Lymphomas have highest diffusion restriction, and many times you can diagnose lymphomas only by the diffusion MRI. That's a very, very important investigation. Now coming to the contrast, we all know this tumor being vascular takes up the contrast extensively. See the contrast imaging. This shows you, see the bunch of vessels within the tumor. Can you appreciate the large vessels within the tumor? This
Yes.
is just the
Yes.
network of vessels. See the kind of contrast it is taking up, and see the various extensions of the tumor. This is all one tumor with various extension. See, the center is here at the pterygoid wedge, and it is spreading circumferentially everywhere. Can you see? So,
Yes.
the goal of surgery is not to enter into the tumor. Exposure, exposure, exposure all around, and then pull wherever the tumor has gone back into the nasal cavity to extirpate out. So, goal is very clear, not to enter into the tumor. Exposure, exposure, and exposure. And you'll see my 90% of the time will be invested in exposure, exposure, and exposure. So that we can control the vessels on the surface of the tumor, control the principal vessel entering into the tumor, and then pull out wherever it has gone. Like in this particular case, I have a very clear strategy. See, this lateral component being too big, it cannot be accommodated in the nasal cavity at one time. Can you see? So my strategy is a planned division. See this. What I will do, this is the level of the lateral nasal wall. Can you see here?
Yes.
We'll take the vessel in control and divide the tumor in the planned fashion at the level of the lateral nasal wall. And then we'll remove the medial component of the tumor. Medial means the nasal cavity, nasopharynx, and the sphenoid component. We'll push in the oral cavity and remove from the oral cavity side. And then we'll have ample of space in the nasal cavity to accommodate the lateral component of the tumor, which will be pulled inside the nasal cavity and remove it. So that is going to be our strategy. That's a usual strategy for larger tumors with a planned division after vascular control. So first goal is vascular control, number one. Number two, see this lateral extension. So my strategy for such tumors is a modified Denkers to begin with, so that we can reach out to the most lateral aspect of the tumor with a 0-degree scope. My another strategy for this particular surgery is use of coblation on the surface. Coblation is like man of the match for this particular surgery, I call it. The reason being, the maximum vascularity for this tumor is towards the surface. And coblation gives you great opportunity to coblate the surface, whatever comes into your picture. So whatever tumor getting exposed, we keep on cobblating to shrink the tumor, to reduce the vascularity, to handle it better without bleeding, which I'm going to show you intraoperatively as well. Third is this kind of, posterior extension. See this tumor where it is going posteriorly. See, it is rising high in the infratemporal fossa, number one. This is another area where it takes additional vascularity. If you see from behind, can you see this? Can you see some vascularity coming to the tumor from behind?
Yes.
This is counterproductive. This is mostly from the middle meningeal vessel. When tumor rises high in the infratemporal fossa, this is counterproductive since we are not embolizing. So we expect some bleeding at this point of time while we avul this tumor from this vessel, and then we will pack it immediately and coagulate it, because the principal vessel we are taking into control. So it doesn't mean that you take the internal maxillary control and it is going to be totally avascular. This tumor, wherever it takes attachment, it acquires additional vascularity from the periosteum, and additional vessel, this is coming from behind, is troublesome, which we'll control with our experience using a coagulation, using Surgicel, using, Surgiflow or whatever material to control the bleeding, which I'm going to show you intraoperatively. So we are going to face some bleeding as well. Now see, from here, this tumor is rising in the inferior orbital fissure. This is orbit. This is inferior orbital fissure. This is superior orbital fissure. And then it is going towards the cavernous sinus, and this is cavernous carotid artery. See how the tumor is in relationship, close relationship with the carotid artery. But we know it has grown from anterior to posterior, going towards the carotid artery. Still, there is a good plane of periosteum intact from the carotid artery, which I am going to show you to give us good sense of relief. I would say that it is not invading the vessel per se, and we'll be able to pull the tumor the way it has gone behind. So all these extensions, believe me, would be a cakewalk once I have a thorough exposure. I will just pick up all these lateral, posterior, superior, everywhere extension, pull them in the nasal cavity, that's it. Because they are extending everywhere, but not invading anywhere. So you have to expose and pull them back to the area of origin. Now see, in the coronal picture, about the relationship of the carotid artery to the tumor. Let me show you. See this carotid artery? Can you see the carotid artery cavernous?
Yes,
Yes.
yeah, you can.
Now see why I'm showing it is saying that it is not invading. Let me change the window setting and see the periosteum which is enhancing. See, I'm changing the window setting. Can you see the enhancing periosteum all around? See, periosteum
Yes,
of the
that
carotid
looks like that.
enhances. This is a very well defined plane between the, see, this is the plane between the tumor and the carotid artery. Can you see very clear?
Yes.
Yes.
That's the kind of MRI you need to give you amazing information. See how to order the imaging. Again, the onus lies on the surgeon. If you order an MRI PNS, the radiologist will do 1 or 2 sequence and get away. Because every sequence has to be shot separately and it takes a lot of time and money. So the onus is on the surgeon when you suspect some pathology, that what kind of MRI to be ordered. So in this particular case, we order CT angiogram, carotids, T2 weighted fat suppressed MRI, contrast multiplanar MRI, axial, coronal, sagittal sections, a diffusion weighted imaging to complete your imaging protocol. If you don't order and just order MRI PNS, the radiologist will do 1 or 2 sequence and get away in 5 minutes. So onus is again the surgeon. Many a time, you know what happens? Patient come to us with the MRI in the hand. MRI, a printout in the hand, which is as good as useless to us. We need this kind of dynamic imaging, a complete comprehensive imaging, and unfortunately, we are forced to order the MRI again with this kind of protocol. So this is something we always propagate. Once you suspect some pathology, you must order complete sequences in your prescription so the complete comprehensive MRI can be done in DICOM format. This is a dynamic MRI. You can compare all the 3 sequences and run together to have a complete 3D information. So this is about imaging. Our case is induced. We are ready to go. Meantime, we are ready to take up any questions, any suggestion. Dr. Rekade, you want me to show anything more on imaging?
No, fine. There is a question about, you probably have already answered those questions. Like, what is your standard investigation protocol for these patients when they walk in the clinic with the suspected master that we discussed? Other question was, when do you do the biopsies? When do you consider biopsy of this? So that also, in a way, you answered that diffusion weighted.
I have answered, and I will repeat again. Yeah. Get diffusion imaging. If you have a doubt on diffusion imaging showing restriction, it can be something else than JNA, and then you have to plan a biopsy. Yes. Any other question?
Having seen all these extensions and in your experience, any recurrent JNAs and all that, have you ever have to consider radiotherapy as a treatment modality, and never. What that situation will be?
I would say never. See,
never.
DNA diagnosis itself is frightening for the surgeon, particularly with such kind of extensions. Like this can be considered intracranial extension. It is intracranial going into the cavernous sinus, no doubt about it. And it has been traditionally discussed that with such difficult extension where chances of complications are more with the surgical exercise, we remove the tumor partially and advocate radiation. This is, I would say, ridiculous in such patient to advocate radiation. These are young patients. Radiation has its own, implications, complications, long-term complications, including future development of malignancy, and we never order. With the improvement in the surgical technique, with the improvement in the imaging technique, with the instrumentation, equipments, camera system, telescopes, image-guided system, now the surgical, field has grown so big, and we have been able to remove such tumor. I have shown you the MRI, giving me clear picture that tumor is not invading the carotid artery. It is approaching, and we can still remove it endoscopically without any fear. So if you have a good exposure, there is no point in subjecting such patient to radiation. This is ridiculous. Radiation is indicated, let me tell you, in our setup. For we get sometimes multiple operated, revision surgeries. The patient operated 5 times, 7 times with true invasion. See, once the primary tumor, I would say this JNA primary tumor is a well-behaved tumor. It has a predictable extension. It has a predictable vascularity, you can say. Now, what happens once you take this vascularity in control and leave the tumor behind, then it acquires aberrant vascularity. Got my point? And many times it becomes more purely invasive tumors. We have seen tumors truly invading the brain tissue, revision cases. We have seen tumor truly invading the carotid artery because they acquire aberrant vascularity from the internal carotid system and become more and more invasive. And in those situations, surgical exercise should be accordingly, directed. And many times we have to resort to the open approach, as I said earlier, for more and more help from the intervention radiologist. And still, if it is truly invading the vessel and the hemorrhage is imminent, you are forced to leave behind some part of the tumor, and then you are forced to radiate. You are forced to radiate. Radiation is never in your primary protocol. In those unfortunate situations, you are forced to radiate to prevent tumor growth, because radiation doesn't kill the tumor. It incites fibrosis. It invites fibrosis in the vessel supplying the tumor, and it ultimately contains the growth of the tumor. It doesn't kill the tumor. So it can regrow again. It can convert to malignant tumor, frank malignancy. We have seen converting into angiosarcomas after radiation. We have got such cases. So this is how our protocol for radiation, which is never in the primary list.
Thank you. And in your vast experience, you're probably one of the world's largest series of JNAs, and you see all the extensive ones. What is the youngest patient you have to operate on with JNA?
Youngest patient I have operated is a 7-year-old child, a very big tumor. Very big tumor. And this is again a big concern. Children have less blood volume. The tumor is more aggressive. And particularly when the tumor comes far anteriorly towards the anterior nares, it becomes so difficult to negotiate your endoscope as well. And many a times in children, because the surgical time again is a big issue in children with the ongoing bleeding. Many a times you may have to taking in all these things into consideration with kind of tumor going anteriorly, big tumor. You may have to resort with the help of intervention radiologists, or ultimately you may have to resort to open surgery with the help of endoscopy, some sort of thing, because you have to take into account all these things in young patients. Elderly, I have operated JNA in a patient who has been operated 7 times earlier, and a 40-year-old patient. 48-year-old patient ultimately invaded the brain and turned into angiosarcoma. So it all depends upon, the pathology. So the bottom line is, this is a primary tumor, and complete removal is the only way to cure. So we should put in everything regarding imaging. Imaging is the best exercise to gauge the true extensions of tumor. With inadequate imaging, you can miss the tumor behind, and again, it can come back. That's why I always advocate, see carefully where the tumor is going. See this. Many a time what happens? See, this is the pterygoid process. Can you see? This is the greater wing of the sphenoid. This tumor has a propensity to invade the marrow bone, particularly the marrow bone of the sphenoid and the clivus, which may be easily missed on surface visualization. Your true imaging will tell you that it has invaded the marrow bone, and then complete removal is the key. You have to completely remove that bone in spite of looking normal on superficial visualization. And this is here, our T2 weighted imaging is crucial. Look at this T2 weighted imaging. This is fat suppress imaging. Can you see? This is our one of the primary, sequence, fat suppress imaging. Fat suppress imaging means it suppresses the fat. Everywhere, see, wherever the fat is, see dark. Now, the pterygoid bone and the sphenoid bone, this greater wing of sphenoid, contains the marrow, and marrow contains the fat. So, wherever is the fat, it enhances. On a regular T2 weighted, it enhances. On fat suppresses, it doesn't enhance. Now, see in this particular imaging, look at the right side of the pterygoid process. It is absolutely dark because the fat is suppressed. Now, look at this. Look at this side. This is dark, absolutely dark. Can you see on the right side?
Yes.
Now, look at the left side. It is enhancing. What is this? The tumor is infiltrated by the, this marrow space is infiltrated by the tumor. Had there been fat only, it would have been suppressed on fat suppressed MRI. In spite of the fat suppressed MRI, you are seeing hyper intense signal. What is that? It cannot be anything else than tumor. Now, this bone on surface visualization, even on endoscopy, may appear normal to you. But I know from imaging that marrow is invaded by the tumor with this fat suppressed imaging. And this is the indication for extensive removal of the pterygoids. So, you can remove the microscopic tumor which is contained within the marrow spaces. Otherwise, it is going to come back. You know, if you see the largest of the series of the revision surgeries, recurrences, whatever, the biggest reason behind the so-called recurrence is the tumor left behind in the pterygoid space, in the pterygoid bone, in the sphenoid bone, in the marrow spaces, which was overlooked by the previous surgeon because of inadequate imaging. I tell you, honestly, that's the only reason. Inadequate imaging, the surgeon doesn't know where the tumor is going deep into beyond the visualization, and then it is bound to come back. Once it comes back, it is going to be more difficult. Any revision surgery is 1,000 times challenging than a primary surgery by all means. So this is how an imaging can save you from the biggest of the recurrences, and that's how I always advocate. See, this for last almost 1 hour, we have been discussing about imaging. This is most important, a tool, believe me, for surgeons to guide. We have now complete information about all the extensions. We have now complete information about the vascularity and the cross flow. We have complete information about the hidden aspect of the tumor in the pterygoid and the sphenoid bone. Can you see? And this is what we expect from the imaging. You know, imaging is technology. And technology is growing at a much bigger pace than the surgical science. And we have to take, now is the time to take the advantage of this technology. And this is what these workshops are the platform to exchange our ideas. And this is always we propagate that your imaging should be adequate, and one should himself, the surgeon should himself or herself be able to read the imaging, because this kind of information cannot be given by the radiologist. We need dynamic information. We need information from surgical point of view. It's not that the static information, tumor is going here and there and there. We can know that, get to know. But how the vessels are entering, how the tumor is growing, how the bone spaces are involved, this best information to be printed 3D in the surgeon mind can be gauged when the surgeon himself reads the imaging. So we should be able to read imaging ourselves to get more adequate information. This is what our message is. Any other question, Dr. Rakade, before we get on to the surgical?
I think we really look forward to that surgery now. That was absolute radiology masterclass on the JNA. So did all the details and each and every vessel. That was amazing. We saw all the branches of external carotid and really traced that to their destination. That was great.
Thank
so
you.
The message here is investigated thoroughly with the CT, MRIs, then a request for appropriate information, and look for all the vascular information on your imaging studies, and so plan your surgical strategy. So look forward to joining you there.
Thank you. So, and feel free to interrupt me during surgery as well for any questions or any queries or any suggestions. any point of time. I would love to be interrupted for more and more discussion. And thank you, Dr. Lewis. Any questions from your side or any suggestion before we embark on the surgical part?
Well, I mean, I think you've answered the question, but obviously it's very extensive and the prognosis. So you would be aiming for a complete clearance of this tumor today.
Thank you.
Is that right?
Thank you. So in a couple of minutes, I'll be back with the endoscopic picture now. Thank you.
Right. Yeah, sorry, Liz, I don't think you heard it there, but
That's okay.
that's probably that was he was alluding to that.
Yes, I think so.
For complete surgery.
That's right.
That just
and I think
incredible, isn't it? It's
it actually is incredible.
Tumor.
It's so extensive, so extensive. But I think it's just
without,
with his experience with the endoscopic resection. That's right.
Correct. And,
that's right. So I'm really looking forward to seeing this. It'll be excellent to see. And I think the point as well of the correct protocols for your scans and the responsibility being on the surgeon to ask for those. Because it's very true. I think when you've got a good relationship with the radiologist in your department, you know, they know what scans, what protocols, what you need. But I think it is on us to ask for the correct protocols so that we get the information that we need to do the surgery safely.
Yep. And there is more and more tendency towards relying on the radiologists to plan that and provide that information. So it just highlights that the surgeon himself have to be sort of very dynamically involved into getting that information. That helps for a surgical planning. It was very beautifully taken through all the 3D planes to get that, in his own words, you need to have a 3D printout of the tumor in your own mind before taking the surgery. Then again, use of coagulation, so that will be great. And seeing that tumor division, I think important point that he makes is the main vascularity of the tumor is along the surface. So you control the surface and then go through the core with coagulation. That seems to be the strategy.
Yes.
And nonetheless, that having IMAX control, the main vessel control, doesn't guarantee that suddenly the tumor becomes avascular. So you still have to be vigilant and be prepared to control the bleeding from the other side. Like in this case, looks like there's some connections from the middle meningeal area.
Yes. And he's prepared to deal with these if that happens.
Right.
But I think, it's quite incredible, actually, I think. Because I think looking at that tumour, I think certainly in the UK, there would, there'd be a lot of hesitation with such an extensive tumour.
Yeah, correct. And we don't see that many numbers. And having that high volume, and this again underlines the importance of having high volume centers. They can provide better outcomes for these patients.
I think as well with GNA, there's the added stress that it's often a child, and also it's a benign pathology. We spend so much time dealing with malignant pathology, whereby, you know what the outcome is if you don't operate, so you can balance the risks of the surgery. Right. But I think the GNA is very unique in the concerns that you have.
से उम्मीद नहीं थी उम्मीद नहीं थी दूसरा कैमरा लेता ना टेलीस्कोप अच्छा ले लेता और अच्छे हैं 4-5 है यार देखना यार hello
yes, Dr. Satish.
Yeah, so we are with the endoscopic picture now.
We're ready.
Let me know when you get the endoscopic picture.
Yes, we can see the endoscopic picture. See the aspirating the mucus.
Yes, so this is all infiltrated secretions. This is the inferior turbinate on this side. And see the tumor behind. Can you see?
Yes.
Yes.
And see the nasal space, which is not very big, not very, I would say, it's a narrow space. What I'm using first, is the decongestion. I'm using these marrow cell pieces soaked in adrenaline to decongest the nasal cavity and some gauze pieces. This, this is tumor, so I can afford to use the gauze pieces. In endoscopic sinus surgery, we don't use gauze pieces, more and more marrow cell to respect the mucociliary activity. But here, this is not immunocompromised situation like, sinus surgery. And see, just applying the topical adrenaline. Our first application will decongest the capillaries and open up the space and prevents its systemic absorption. We never inject in the nose for anything. Can you see after the first application?
Yes, yeah, I can see.
See how the nasal space has opened up. See, much better now?
Yes.
So this initial preparation is very, very important. See, in endoscopy, the visualization is the key. And to maintain in order to maintain the visualization, the bleeding should be minimum. And this is afforded by your all the help from the decongestant, from the anesthesiologist. This is one surgery, unlike sinus surgery, where we go for or request our anesthesiologist to give hypotensive anesthesia. This is one surgery. In sinus surgery, we never ask for hypotensive anesthesia because there the source of bleeding is capillaries, and here pure arterial bleeding is expected. So we expect our anesthesiologist to give hypotensive anesthesia. We load these patients with a fluid, with starch, whatever, so that whatever bleeding happens is the diluted blood. So there are a lot of strategies from the anesthesiologist side to help this tumor removal by endoscopic approach. See this tumor which was rising up, that's not invading anywhere. Can you see?
Yes. Yeah.
Which is pushing down with my gauze pieces, and see the middle turbinate in front of you. So this is how you can see how the tumor, this is tumor, and from the surface you can see it is looking, angry. This angry looking picture is classical of Japanese. Now, my man of the match tool, which is coming into the field. This is what? Coblation, and this is the vent I am using, is a Pro Size Max. And see what I am doing. This is my man of the match tool. I am doing surface coagulation. Can you see?
Yes.
This.
So what are the settings, Dr. Satish? You use coagulation?
Yeah, full. Full on 9 and 5. देखा तो करो पहले. See this? This is giving surface coagulation. Can you see?
Yes.
This particular tool is a wonder tool which has the ability to irrigate all the time. Can you see this? It has the ability to coagulate. It has the ability to cut as well. One tool along with the suction to take away the blood and the secretion from the field to give you amazing visualization. See during entire surgery, this one tool will be working and giving you all the things which you expect. So what I am doing is surface coagulation, because at any point of time you happen to touch this tumor with your instrument, it starts bleeding. So this surface coagulation, first of all, takes the surface in control to prevent bleeding with the instrument. Number two, it shrinks the tumor as well. See, maximum bleeding in this tumor is toward the surface. As the tumor grows bigger and bigger, the more and more central part becomes necrotic. So this is how This tumor has to be accordingly handled. See, whatever tumor which comes in your view, keep coagulating on the surface. See how the surface is being coagulated. Can you see clearly?
Yes. Yeah.
I hope the picture is good there.
Yeah, it's a very good quality. You can see it very clearly.
Yeah.
Thank you.
Thank you. Let me know for anything I can do more
Yeah.
regarding
We can
picture
see that
and
tumor is
vision.
getting is shrinking down as well. So more and more landmarks are coming in view. We could just had a glimpse of a middle turbinate.
And I'm grateful to Mr. Dinesh for this telecast. I am so used to working with him as a sort of addiction he has given. The kind of comfort he gives with the live telecast is amazing.
Yeah, it's a fantastic work, and the quality of transmission is really wonderful.
See now the surface. Now the more nasal cavity has opened up, and this wonder tool, which has all abilities. Now, I told you in the beginning, we will never think of entering into the tumor in the beginning before taking the vascularity in control and before adequate exposure. Okay? So now my first part of the exposure will involve a modified Denkers. Modified Denkers means, see, this tumor has gone laterally, and there's a lateral wall of the nose, which is the biggest obstacle to to reach out the tumor. So we have to remove this lateral wall of the nose or the medial wall of the maxilla along with the anterolateral wall to get on to the most lateral part of the tumor head on with 0-degree endoscope. So this is the modified Denker's approach described by Sternman and Canfield is amazing. It gives you a good paramedian highway to approach all these tumors. And so in order to remove all this, my landmarks are, my superior limit is the orbit. I will show you under vision how we spare entering into the orbit, how we stay away from the orbit. So in the beginning, again my tool will be coagulation. This is the axilla. So I stay roughly a centimeter below the axilla and coagulate this periosteum. See, this is a richly vascularized area. And see coagulation. It takes care of all the, with the coagulator. See, we can coagulate the surface to minimize the bleeding. This is my man of the match. So this involves removal of the maxilla, medial wall of the maxilla and the inferior turbinate, which is a separate bone. See this? I am coagulating not only the medial wall of the maxilla, but the inferior turbinate as well, which is a separate bone, and this inferior meatus as well, so that we can flush the bone removal up to the floor of the nose. And
So there is a question for you. That there is a question for you.
Yeah.
That we haven't seen the navigation mentioned yet. So
navigation,
do you use surgical navigation? Good.
Navigation most of the time not needed, yet it helps you improving your localization. With experience, the need for that is more and more reduced. I am not against it. If you feel like using it, you can use it. Now see, this is the initial coagulation. See this? And my anterior limit is this bone. This is pyriform aperture. And we are not supposed to go far anteriorly here. See, almost a centimeter anteriorly here. This is the lower ala, which should never be destroyed. Otherwise, it will give some deformity and need some rhinoplasty correction. Now, my next goal is I am using the cutting for the first time and remove this periosteum. See, removing this periosteum to expose the bone now. Can you see?
Yes.
What an amazing cutting tool with no bleeding at all. That's the beauty of the coagulator. See the visualization. Endoscopy means visualization. See, my coagulator gives me amazing opportunity to go bloodless. And see, I will show you my anterior limit soon. Can you see the bone of the pyriform aperture now?
Mhm.
Yes, very
Yes.
clearly. So,
This is my anterior limit. See, this is our anterior limit. And my lower limit is going to be till the floor of the nose. Wherever is the bleeding, you can always use the population immediately. See, from top to bottom, the entire pyriform aperture. Can you see the pyriform aperture thoroughly now?
yes.
Yes.
See this. Now I told you this is a separate bone. This inferior turbinate is a separate bone. See this turbinate? Can you see this?
Yes.
Yes.
This is the turbinate. Later. Find all. See, I have fractured the turbinate like this. That's a separate bone. हटा यहाँ से हटा. हटा. Yes. Now I am removing this periosteum of the inferior meatus. Can you see?
Yes.
Yes.
And see, my lower limit is the floor of the nose. See this?
Mhm.
Completely flush. Now this cobbleter helps you control this thing better because the inferior turbinate gets its milk from the vessel, which is a branch of spine runs through the turbinate from behind. Still, the cobbleter helps you control that bleeding effectively. यहाँ से जा रहा है. हटा हटा. See this? This turbinate has to be removed to expose my lateral wall thoroughly.
And do you use a cobblator for all your tumor work?
Pardon?
Do you always use the cobblator for your tumor work?
Yes, yes.
Yes.
Always. Cobblator is the key for everything.
Mhm.
See the kind of comfort my one hand is using cobblator. Other hand, I am holding the endoscope, and this cobblator is everything: suction, irrigation, cutting, coagulation, everything in one in this magic wand.
So
I
you're
hope the
cobbleting
picture
all the
is-
soft tissue, turbinate soft tissue, really.
Yes, see, there's no bleeding at all.
Mm.
And we are reaching more and more behind
Mhm.
without any issue. See this?
Yes.
Mhm.
This is a tumor. This is a one component which has various extension, and we have to expose all. And all the intervening bone has to go. The principle behind this surgery, efficient, I would say, endoscopic surgery, hatana, is the exposure. Exposure. Inadequate exposure will invite complications. दूसरी बैंड भी रखना वो वाला See this? Till this? Now the entire lateral wall is exposed. See completely?
Yes. Yeah.
We have dealt with this extremely vascular structure without any issues. Now, see this, the pyriform aperture. Now I will go towards the anterolateral wall, and this tumor has massive lateral extension as well. See this? Subperiosteal towards the anterolateral wall section. And see, it severs lot of neurovascular bundles. See this carefully.
Yes.
These are
Yeah.
all superior alveolar neurovascular bundles. See the now, anterosuperior alveolar nerve branch. And we have to sever this to reach laterally. My usual lateral limit is the V2. Usual lateral limit. If you really want to go further for more lateral extension, there's a technique described by Professor Paul Casanova as V2 transposition. If you transpose the V2, you can go 360-degree even all around and beyond. See, this is the V2. Can you see this?
Yes.
Yes. Yeah.
This is the inferior orbital foramen. So right now I'm not going beyond that. It's not needed in this particular case. And see,
Do you develop any numbness afterwards? Any temporary numbness?
for a couple of weeks, definite numbness, because it supplies all the canines and the incisors, upper canines and incisors, and this now has numerous, ramification, communications. Ultimately, it regenerates, with other branches, and most of the time it doesn't bother in long run. So this is
That's good to know.
expected that you have to tell your patient before as well. See this bone exposure. Niche section. Complete exposure of this bone. See here. Now I will punch out this thin bone, anterior bone, and then will enter the maxillary sinus. This thin bone can be punched out with a lux forceps, or any bone punch, whatever. See this? And now I am going to use with my high-speed drill this state-of-the-art Medtronic. See this? This is transnasal burr, which is a inherent 15-degree curvature in the shaft. So the shaft doesn't come in the way. See what I'm doing? To show you my superior limit. I want to see my superior limit of the maxillary sinus first, so as to avoid unnecessary entry into the orbit. See now, I have entered into the maxillary sinus head on. Can you see?
Yes.
Yes.
Yeah.
Which will show you inside picture soon. Let me widen a little bit. Action. See the interior of the maxillary sinus. See that?
Wow. Yes.
And what I
Yes.
intend to see is my superior limit. With this Denkers, I don't want to damage the orbit. I don't want the unnecessary, unwanted orbital entry. So until the orbital roof, I can go up. And 3. इसको पकड़ा दिया तुमने. Section. He's just showing you the orbital floor, sorry. The sinus roof, which is my superior limit. I want to expose this sinus roof thoroughly so that I can define my superior limit adequately. See now inside this prominence in the medial wall. This prominence here belongs to the nasolacrimal duct. Hello?
Yes.
In this surgery, the only important structure which comes your way, only vital structure which comes your way is the nasolacrimal duct. And you have to obviously transact it to go ahead because it comes in your way. The best way to prevent epiphora is to cut it flush with the level of the orbital floor. If you cut flush with the level of the orbital floor, it doesn't come your way. Let me show you. इधर सक्षम कर हल्का से ट्यूमर को दबा हल्का always. See this? This is your entry into the maxilla. Can you see the level of the orbital roof? Orbital floor?
Yes.
And this is the level you have to remove this bone until then. So, since the bone is thinned out, so I can afford to remove with my punch again. See this? Under vision more precisely and see behind is your nasolacrimal system. Can you see the nasolacrimal duct?
Yes.
This is your nasolacrimal duct, this one. I hope it is very clear.
Yes, you can see that.
Nasolacrimal duct. So we will flush this bone until the level of the floor of the nose. So that I can cut it flush to prevent an overhanging duct. This is a strategy to prevent this duct getting fibrous and giving epiphora. पानी मिलेगा सक्शन मिलेगा उसको देना है एक काम तो ढंग से कर ले यार बंद करो see where is soft tissue bleeding you can use your cobblator see this
Yes.
my duct is very much hanging in my field. Can you see very clear? I will further improve my, exposure. Some more lateral first. जाके डाल ले छोड़ गुस्सा दिलाता है चला see all this bone I have to flush with the floor. Can you see? This is important so it doesn't affect the instrument, deeper instrument. It should be thought with the lower one. So I am quickly flushing it with the floor. Action. Just to reorient you. This is the lower bone I am removing.
And does this approach always give you enough of a lateral access, or do you sometimes have to combine it with coming from the contralateral side through the septum?
Contralateral side. Hello?
Yeah, sorry, can you hear me? Does this approach usually give you enough access to the most lateral extent, or do you sometimes need to combine it with an approach coming from the contralateral side through the nasal septum?
Yes. So, in our strategy, I will come later. Whenever this tumor grows towards the midline, it can acquire the vascularity from the contralateral circulation. So, we are very careful about that and control. I will show you once I will reach to the midline when we separate the tumor from the nasal septum and the nasopharyngeal roof. Can you see the maxilla head-on, maxillary sinus?
Yes.
So I will get more exposure by flushing with the floor. This flushing with the floor is very important. This is very important for your instrumentation later on. Flush. See this? The brighter. See everywhere. The more and more exposure is the key. I have removed the part of the lateral wall. See, I have defined my level of the roof of the maxillary sinus. Can you see very clear?
Yes.
I have defined the level of the floor of the maxillary sinus, level of the floor of the nasal canal. Here, can you see?
Yes.
This is my required lateral exposure, This is very, very important to have adequate exposure. Now I will remove this bone, the thin bone, and will remove all this lateral wall bone until the posterior wall. This all lateral wall bone until the maxilla. This is the uncinate process now behind. See what I am taking out. I am flushing with the floor. Everything coming in the way has to go until the posterior wall. Quickly. Debrider. And see the nasolacrimal duct overhanging, which will take. See the posterior wall of the maxillary.
Yes.
See, this is the remnant of the uncinate process. This is, let me show you my nasolacrimal duct. See this? Getting it out of the bone. Out of the canal bone. See this?
Yeah.
I'll remove this entire bone all around. I am removing this entire bone all around. The brighter. See the entire bone all around being taken care of. Can you see all around?
Yes.
See the nasolacrimal duct overhanging. There is nothing all around. And now this is the time to do a sharp transaction. See this?
Mhm.
The sharp transaction of the nasolacrimal duct. Can you see above?
Yes.
See, this is the nasolacrimal duct which has been transected. See? So now it doesn't overhang. It's not going to come into our field anymore. What my point? And this, since it is not going to overhang below, this is not going to get fibros and give epiphora.
Mhm.
If otherwise, if it gives, you need to do a proper endoscopic DCR further. See now, the posterior wall is flush with the lateral wall. Very clear? Now a little bit of the lower part is still there, drill, which I am going to flush with. Viru, see this, the wall of the maxilla? This I will flush thoroughly with the floor. Till posterior wall. Everything has to be thoroughly flushed.
And is this the 15-degree transnasal burr that you're using?
Yeah, so this is, let me tell you, this is a wonder burr. See, this is pure transnasal, such a sleek burr with a natural 15-degree curvature. So when you use inside, your shaft doesn't come in the way. But my point?
And is that is this
I was using
coarse diamond burr?
I was using at a speed of 60,000 to 70,000 RPM. This is a single-use burr. Cost is a limiting factor, but this is simply amazing. Simply amazing tool for the skull-based work.
Yeah, and the burr that you're using, is it the coarse diamond burr?
Yeah,
it's not a cutting burr.
Yes,
coarse diamond.
Absolutely. This is very, very safe. Coarse diamond burr. With I'm using the 0.5 mm coarse diamond burr. See, wherever the soft tissue bleeding is, you have to use the coblation. Now more tumor is coming into picture. See this? More and more surface coagulation is required. More and more surface coagulation. This tumor has a propensity to invade certain structures and spare certain structures. This tumor, as I said earlier, never invades the paranasal sinus mucosa. See this? This tumor preferentially invades the turbinate and the septum. This is middle turbinate, which is almost always an attachment with the tumor. See this? So wherever the mucosal surface, I am coagulating to improve my field. And see the value of coagulation. Simply amazing. Now behind this paranasal sinus mucosa here, see, I am removing this maxillary sinus mucosa thoroughly. See this?
Yes.
Behind that is the pterygopalatine fossa, which is our area of interest. See, only one tool is working, that is coagulator.
And you've got thinning of the bone there, and it's all the tumors breaking through.
Yes, you're right. See this bone, it is bulging. Can you see this?
Yes.
Because of the tumor pressure from behind. The huge tumor
Dr.
behind.
Satish,
yes.
Apart from this JNA situation, do you use a coagulator in any other sinus surgeries?
Yeah, not in sinus surgery. Adenoidectomy, it show you in based procedures. In CS synovial, I will show you the case today. And all based procedures, even in the intracranial procedures, it is very, very safe to be used even on the brain.
Okay. Or even difficult nasal polyps which are bleeding, did we use them?
So here, but it has to be used judiciously whenever you are using the cutting part, because cutting is ability very fast, you know. And see here on the bony surface, I am not using complex bony surface, but that will ruin my blade. So bony surface, I am using this. Okay. Can you see that?
Yes.
Never use
Yes.
the complex. It is only. Yeah. So this is my initial part of the exposure after the Denkers. Can you see very clear?
Yes. Yeah. That's
Now, what
amazing.
you
Very
see in
wide.
front,
Good.
what you see in front is your posterior wall of the maxilla. And we have reached now head on. See, in the entire surgery, in spite of, extreme lateral and superior extension, throughout the course, I'll be using only 0 degree. 0 degree gives you best visualization without any disorientation. And the principle of skull base is to use 0 degree, 0 degree, 0 degree, except in certain situations when you have to look into the corners, you can use angled scope. But the primary scope is 0 degree, always. See, the entire maxilla is exposed thoroughly. Can you see very clear now?
Yes.
And all the time, the visualization has to be improved with. Visualization has to be improved with coagulation, coagulation, except on the bone. Yes. So this is my initial, exposure, and see the bloodless field. See the bloodless field. My next goal is to get into the pterygopalatine fossa. This bone is the thing which is in between, which has to be removed. See now, because of the tumor pressure, this bone becomes more thin. More the tumor pressure behind, more the thin bone it is. Yes? Many times it is paper thin. I can thin out and remove this bone with my drill. I can use my chisel and hammer. I can use my punches, anything. See, I'm using light. See this cracking the bone with the chisel and hammer. It has become so thin. Look, I can remove this bone like this.
Wow. You're opening the door.
Yes. So now the next structure we come across is the pterygopalatine fossa periosteum. See this? The pterygopalatine fossa periosteum. I am coagulating the periosteum just to maintain the field. See this? I hope the picture is clear.
Yes.
Now I can use safely the punch. See this? Expose more and more. you have this tumor far behind and lateral and up, everywhere. Okay. Behind the periosteum would be the tumor, and on the surface of the tumor would be the vessels. कर दिया अब करने का काम करता ठीक है यार be more and more exposure. I am removing more and more bunch. See how the tumor is bulging. I am removing this entire intervening bone. All bone being removed. See all intervening bone between this part of the tumor and this part of the tumor. Divider. See all intervening bone coagulation. Now a little bit of potassium. See the fat coming from the you see?
Yes.
Further coagulating on the surface to optimize my field. See this field? This is the turbinate. See this?
Yeah.
I am taking out part of the lower part of the turbinate in between to show you both parts of the tumor in continuity. See both parts of the tumor. See this? That's the
Yes.
bottleneck. Can you see the bottleneck?
Yes.
See the
coming out of that.
bottleneck. That's a part of the turbinate. See my nasolacrimal duct up in the field. Can you see?
Yes.
But not
Yes.
bothering us. Not bothering us. We have cut it sharp above. Now see this part of the tip. All intervening bone has been removed. See this? Now my next course, Uday, put out. My next course is to, catch the vessel before going further anywhere. Just leave it. Now see, we have to go behind this periosteum to catch the vessel. Okay? One of the most important part of the surgery. This is level of the floor. We know where the vessel is likely to be. What I am doing here, Hmm. See, I am cutting the sickle, the periosteum to open up this space. Can you see the tumor?
Yes.
Yes.
See, I have opened the periosteum. And see, this is tumor, pure tumor. I am taking away the periosteum. This rest of the periosteum. Tumor is bulging. This is a tumor. Now, in this lake of tumors, you have to identify the vessel. Big challenge. Big way. I'm trying to segregate and identifying the vessel. Can you see?
Yes.
Some fat which is prolapsing, which I am going to, remove and empty this field. This is the fat I am removing.
So again, a very similar technique continue with the coagulation.
Coagulation is the key. Uthaya. Now the goal is to look for the vessel. Can you see the vessel?
I can see that. Wow.
This vessel has a tortuous course in the fossa and the intratemporal fossa. Tortuous coagulator with the tumor coming in between. See this? I am first here. Can you see this vessel?
Yes.
Which I am looping. See this? See the big vessel?
Yes.
Yes.
And now here, I am putting a clip over it. See this? नहीं हाथ आ रहा तेरा.
Yeah, see there.
No, give me one more. हाथ आ रहा है. दिल बहुत रहा है. बहुत चल रहा है. एक्शन करो. This is one vessel. To me, that look the main vessel supplying. So I will coagulate it. See this? Hello?
Yes.
Yes,
Yes.
It's a very nicely dissected. And so far, there are hardly any bleeding, isn't it?
Yeah.
Mhm.
Probably.
Yes, yes. So I'm looking for the trunk now.
So is that the main trunk that we saw on the scan that you're exploring now?
Can you see this?
So you need, yes.
This
Yes,
is the main
yes,
trunk.
that's very
This
clear.
is the main
Yeah,
trunk. यूं पकड़
that's
के
the main trunk. And that's the one we saw on the scan, correct?
Yes.
Okay.
And now I will put my clip.
Look around it.
Clip is the most secure way of taking this vessel in control. See this?
Yep.
A coagulation can reopen later on.
Mhm.
I will, on the safer side, use multiple clips. See, the tumor pushes the vessel anteriorly. इसको काम दे गया.
Do you ever have to ligate the internal maxillary artery again as you come
Yes.
round laterally and posteriorly?
Posteriorly, I have seen this one entering the tumor from within, not anteriorly many a times, within the lobulations of the tumor, and that's difficult to dissect it off.
Mhm.
So your CT angiogram can actually tell you what exactly the course of the vessel. That's why CT angiogram is damn useful. See this vessel now?
Yes.
Clipped
You're
on the
dividing
either
the
side.
population again.
Clipped on the either side. And I'm transecting it. See this?
Yeah.
Yes.
That's control.
Giving the major, devascularization of this tumor. No, this is not devascularization to the level of the capillaries. We call it intraoperative embolization without actually doing embolization. Cutting चल गई वहाँ. See now, once you are devascularized, by mistake I, pressed on the cutting. So just went into the tumor, so it started. So what you can do, you can use your Surgicel and leave it for a while. No issues. You have devascularized. This is one component you have exposed. See the lateral part of the exposure? We have done anterior exposure, we have done anterolateral exposure. Can you see very clear?
Mhm.
Yes,
Yes.
yeah, we can see the two components very clearly.
And now we will go all around. We'll do superior exposure and separate from the paranasal sinuses. We'll do medial exposure, go across the posterior part of the septum to go to the nasopharyngeal roof. See this tumor going in the different
Yes.
lobulations? Yeah, upper section. Yes. And see, this is the turbinate, which is which was bothering earlier. See, just read it up. I am
I think
cutting
this is a
a
good time to
little more.
summarize the case, really, for the sake of those who have joined a little later. I think Dr. Satish Jain from Jaipur in India is demonstrating surgical procedures today. We have our final day, third day of our live surgical event. We have very interesting cases lined up. So this case particularly, very extensive journey in a 12-year-old. It has not been embolized. We've gone through the imaging studies, through the CT and MR. We looked at all three planars. So we looked at
What I'm
the
doing.
tumor is extending laterally, then into pterygopalatine fossa, then again into along the infraorbital fissure, along the sphenoid towards the cavernous sinus. So
Sir,
the
can I
surgical
interrupt you?
strategy here is extensive use of coblation and then a modified Denker's approach. So surrounding the tumor and then trying to aim for the main feeding vessel, which is IMAX. We just saw that Dr. Satish has explored the IMAX and had ligated, like put some ligature clips around it and then divided it with the cobbler. So it's a beautiful demonstration of how to use a coblation for surface coagulation and then deal with the tumor. So getting a good hemostasis, good exposure before you get to the tumor. So the strategy is to tumor as two distinct parts, the medial and lateral, to divide in the center and then deal with them separately. So thank you. Anything to add, Luis?
Boss, I am doing adenoidectomy now. I am superior to the tumor. See, the tumor is below. This is one component which is extending up. Give me a gauge piece, small gauge piece, to push it down. See this component, this lobule of the tumor. And what I have done is anterior adenoidectomy, keeping my lamina papyracea as my lateral limit. To show you something, I told you this tumor can rise high in the ethmoidal roof or even, erode the ethmoidal skull base, but doesn't involve the mucosa. And see, this is the ethmoidal cavity. And keeping my lamina papyracea as a lateral limit. This is lamina papyracea. See this. Doing my ethmoidectomy and going behind. See, there is no tumor in the ethmoids. Can you see?
Yes.
Yes, they're clear.
Clear.
See, superiorly, the ethmoidal cavity is crystal clear. Now, this is your superior turbinate. I am removing part of the superior turbinate with my shaver only. Yes. Now look at the ethmoidal cavity. Very clear?
Yes.
It's staying on the top of the tumor. See this? I am removing this ethmoidal floor. See this? See all the way tumor.
Yes.
I am giving superior exposure of this tumor. This is superior exposure. This is superior exposure. All ethmoidectomy everywhere. Debrider. Funny. See now, this is, can you see?
Yes.
This is onodi cell. See the optic now. That is onodi. Can you see that? Beyond that is onodi. That's the optic now. Now my sphenoid is pushed medially and inferiorly. See there. Now this is the part of the superior turbinate which I am removing. To enter into the sphenoid sinus. Let me remove this part of the tumor later. This tumor which is coming in the instrumentation and bleeding again and again. See this? The small of the tumor which is superior-medially. This one. Now my sphenoid is here behind. See this? See the tumor within the sphenoid sinus. Can you see?
Yes. Yeah.
Let me make it clearer for you. Part of the superior turbinate. And this is the septation between the sphenoid and the postethmoid divider. And widening the sphenoid sinus, and I told you this tumor never ever involve the paranasal sinus mucosa anywhere. See, this is the sphenoid sinus. See the sphenoid mucosa. See the sphenoid mucosa behind?
Yes.
And this is the tumor within the sphenoid sinus. Let me widen the sphenoid more to show you better. See, this is sphenoid sinus. Harrison. Coblation. First coblation. Let me apply some coblation on the surface where it is bleeding. Surface bleeding.
So as you said, Dr. Satish, it looks like there's a good plane between the sphenoid mucosa and the tumor without any invasion as such.
Pardon?
It looks like there is a good plane between the sphenoid sinus and the tumor. You just
yes. So it doesn't invade the mucosa. I told you again and again, they never involve mucosa. Hata. See, whatever tumor which is coming in my exposure, I am coagulating. See more and more exposure?
Yes.
The tumor surface. Always use coagulation on the surface to minimize the bleeding during tumor handling. See this? Now this anterior wall of the mucosa, I am widening. Anterior wall of the Harrison. See this anterior wall, I am going to widen to get the full view of the tumor of the sphenoid sinus. See this? See, I am widening the anterior wall. Widening the anterior wall. See how the tumor is freely occupying the sphenoid sinus. See this? It has gone from here. Can you see the defect in the floor?
Yes. Yeah.
This tumor has gone here and I am widening this defect so that again we can pull it down. Okay?
So that's your bottleneck there, right? So
yes. See, that's the defect in the floor. That's the defect in the floor, which I am removing. Widening this defect. So this tumor again can be pushed back in the sphenoid, in the nasopharynx. See this? I am widening the floor. See this tumor, I can again push back in the nasopharynx now. Can you see very clear?
Yes.
See this tumor, I can push it back down. See the sphenoid sinus inside.
Yes.
Very clear?
Yes, absolutely.
It has gone up from here. I will similarly push it down. So I have widened the axis. And see, this is all periosteum attachment which I am taking care of. See, tumors, periosteal attachments. See, these are the periosteal attachments of the tumor. See how this tumor has gone in the sphenoid sinus. And sphenoid mucosa is never involved. That's the best part. Similarly, we will pull it back. Okay? See this tumor which has risen up in the sphenoid sinus. This is the tumor component. See, this tumor component is bothering us again and again. What I will do now, I will cut it off without any problem. To give additional exposure. See, I'm cutting with a cobbletter. It is like
I see hardly any blood.
cutting the butter. It is like cutting the butter. See, I am cutting the tumor, yet without any issues. See this?
It's quite amazing how little blood there is.
See now the tumor in the sphenoid sinus and the sphenoid sinus mucosa is uninvolved. Can you see all around?
Yes.
Yes.
This tumor is bulging from below. From here, I widen the axis from below and similarly I will push it down. I hope it is very clear. So this is the superior exposure of the tumor. Now see in the paranasal sinuses. Now what Dr. Lewis was saying, that attachment towards the midline. Can you see this tumor attached to the septum?
Yes.
Yes.
This is very important, crucial, as Dr. Lewis mentioned, because it can on the opposite side as well. See this? I am cobbleting the periosteal attachment. Cobbleting the periosteal attachment under vision. See very clear? And then I will segregate, completely segregate from this periosteum. That's it. No question of blood supply now coming to the tumor from any other side. The tumor completely segregated off the septum. Can you see very clear now?
Yes.
Yes. Yeah. See over the periosteum.
So this tumor is now bulging in the sphenoid and I have adequate access, I have made to pull it down. See this? This access I will further widen by removing this chunk of bone over here. To widen the access. See now? This chunk of bone I am removing to widen the access. See now? This entire tumor can be pushed down straight without any problem. Can you see the tumor?
Yes.
It has gone up in the sphenoid. The way it has gone up from below, we have widened the axis to pull it down. Debrider. This is to show that how this tumor can easily be pulled down into the sphenoid, into the nasopharynx. See, the sphenoid axis has been widened. See the sphenoid sinus mucosa. this bone in the floor needs to be removed further. The tumor can be pushed down easily. See this?
Mm-hmm.
Now see, there is no obstruction for this tumor to come down. See, this tumor is, I can pull it. It is dying to be out like this. See this?
Yes.
I am not doing that right now. See now the superior, this medial exposure towards the septum. Right. Okay? So I will just leave a gauge piece to keep my field good at this point of time over here.
So,
I
Dr.
hope
Satish,
this-
there's a question about internal carotid artery in a sphenoid.
Yeah.
I mean,
So
how
internal
do you
carotid
sort
artery
of
runs
deal
to
with
the
it?
post. Pardon?
How do we deal with this in this situation?
This tumor doesn't invade the mucosa. Artery is beyond that. Not only mucosa, but there is a bone also behind.
Yes.
This artery never goes, this tumor never goes directly to invade the carotid artery from the sphenoid side. It goes cavernous sinus and carotid from the orbital fissure side. I will show you that extension and remove it under vision.
So even if there is a carotid artery dehiscence, the bony dehiscence, there is a mucosal protection, correct?
See now the exposure? The lateral, the superior and the medial exposure. Can you see very clear?
Yes, it's very clear. Very wide.
90%
Surrounded
of
the
time
tumor
will be
nicely.
invested in exposure, exposure and exposure. Now I will expose posteromedially because this tumor is occupying the nasopharynx, going to the opposite side and taking a very important attachment to the nasopharyngeal roof, which can invite the blood supply from the opposite side. See this? From
Mm-hmm.
of the tumor, anterior surface of the tumor here, I will do a posterior septotomy here. See this?
Mm-hmm.
Only this posterior most septotomy to go to the opposite side. See this? This is posterior septotomy or septectomy, whatever.
Mm-hmm.
To go to the nasopharynx of the opposite side. See? To see the tumor extension to the opposite side and segregate pharyngeal roof attachment, which is an important source of bleeding. Very, very important source of bleeding. And after that, my tumor removal will start. Carefully remove the entire bone. I told you between the various components of the tumor, no intervening bone should be left.
Mm-hmm. Do you find if it's a revision case that it can often be much more scarred and fibrotic when between the junction of the tumor and the mucosa?
Yeah, see, this tumor doesn't invade the mucosa as such,
Mm-hmm.
except at certain levels I mentioned, where it invades the like septal turbinate.
Mm-hmm.
See this? The opposite side, inferior turbinate, can you see very clear?
Yes.
Can you see?
Yes.
See, I have gone to the nasopharynx on the opposite side. See this? Opposite, Eustachian tube. Can you see?
Yes.
At this point of time, let me use my pen. On the edge of the septum, where it bleeds a little bit. contact with the inferior turbinate where it can bleed. See the nasal floor. And here toward the roof. See this can bleed surface. Now, this attachment to the nasopharyngeal roof, this tumor never takes attachment on the adenoid surface. Never. It takes attachment on the periosteum of the nasopharyngeal roof. See this? And here I am truly segregating. I am using now cutting to cut the periosteum to segregate the periosteal vessels from the opposite side. Can you see this?
Yes.
Completely segregated till depth. So no opposite side bleeder can contribute now this tumor to this tumor. Can you see very clear?
Mm-hmm.
Very clear. See this opposite side has been segregated. There should be no doubt about it. Let me remove this gauge piece to show you better. See the opposite section. See the opposite side is segregated very clearly.
Yes. Yeah. Yes.
There should be no doubts at any step.
So on the opposite side, you've come down right on the face of the sphenoid. Is that correct?
Yeah, that is the sphenoid face.
Yes.
And this is the keel below. Can you see this?
Yes. Yes.
And see below that the entire periosteal attachment has been sacrificed.
Mm-hmm.
No attachment should be left to acquire the blood supply from the opposite side. See, I am everything coagulating.
Yes.
This is very, very important to ensure that no bleeding should come from the opposite side vessels. See this? This is midline. Now everything done. Now this is the time to plan your tumor removal. See this? You're exposed from all around. I told you my majority of the time is going to go in exposure.
Mm-hmm.
And I told you in tumor removal, my strategy of planned division, I told you in the beginning. I told you we'll divide the tumor at the level of the lateral nasal wall in a planned way, if you remember. Remember?
Yes. Yeah. I think
Yes.
we'll come to that point now. Since you can clearly see that bottleneck.
Yes. एक section नीचे रहो.
How does the coagulator work on a softer tumour such as a schwannoma?
On?
Does the coagulator work well with that as well? Would you use, say you had a trigeminal schwannoma, for example?
Yeah, the approach is same.
Same.
Approach is same,
And
but that is not that
coagulator works
vascular.
well.
Now see, this is the bottleneck. एक section नीचे रखे ऊपर. See, this is the bottleneck. Can you see?
Yes.
Where I earlier
Yes.
entered into the tumor accidentally. Bipolar. Here. Later. See the bottleneck of the tumor in the medial. This is lateral component, this is medial component, and medial component the sphenoid. Can you see here?
Mm-hmm.
So we're ready to divide the tumor now, right?
Yes. One day. See now what I am doing. See, I am doing what I am doing. I am connecting this pedicle with a bipolar. Can you see?
Yes.
Yeah.
So before dividing, I am additionally ensuring And I will immediately divide with the cobblator. Then I answer the. See this? Further coagulating this tumor surface so that I can divide with the cobblator. Can you see very clear?
Yes.
Between the medial and the tumor. This is planned division. जल्दी कर यार 5 कर ये now see yes see my cobblator
Yes.
this is again coagulation पकड़ना है पकड़ इधर कर now I am dividing with the cutting. See, I am dividing at the level just bang on the bone. Why do deep section रख I am going bang on the bone. See this?
Yes.
Yes.
Section करना पीछे bone देखा. ये see I am going bang on the bone.
So there's the pterygoid.
Yes, that's the pterygoid process. See the medial part of the tumor. Fungal part. Can you see?
Yes.
That's the medial part of the tumor. That's the lateral part. Completely segregated. Some oozing here will continue. This is the pterygoid component. See this pterygoid bone component. Now go there, suggestion. See this pterygoid bone component. This tumor is within the bone of the pterygoid. This tumor is within the bone.
We saw that in the fat suppress MR that
so what I will do,
the pterygoid was infiltrated.
What I'll do, I'll just place a Satish cell on the surface and press with the gauze. Nothing.
So, Dr. Satish, is this the vascularity we were seeing on the fat suppress MR? That the tumor, with possible tumor infiltration within the pterygoid?
Yeah. So this vascularity is from the pterygoid bone. See, tell you there are 3 sources of vascularity. See now, one is from the external carotid system, which is principally the internal maxillary, which you either or take under control like we did, because principally it is from internal maxillary and we took intraoperative control. Number 1. Second source of bleeding when tumor grows further to the skull base is from internal maxillary artery, internal carotid artery, which you cannot mean mobilize. You like it, you cannot do anything to face it. Like here, from the pterygoid venous plexus, see which we have pressed. This again cannot be embolized. But to face it, I have to control it later on. So I have pressed with the watch piece. Can you see?
Yes. Yeah.
Now my medial tumor and the lateral tumor are 2 different components. See this? So now I will remove the medial tumor. It is 3 parts. the part which is rising above in the sphenoid. See this? I will pull it down now. See this?
Yes.
It comes like a baby. See, it has come out of the sphenoid because it doesn't take attachment. And we see how much the sphenoid was widened. See now, this is on the
Yes,
anterior face
vidian.
of the sphenoid. It is out of the sphenoid so easily. And now, here, it has some periosteal attachment to the sphenoid.
Probably coming to the vidian area there.
See this? Which
Yeah.
I am going to separate, which I am going to later.
Well, Satish, we're coming close to the vidian now, essentially.
Yeah, we destroyed in the, I will show you. See now how the tumor has been fallen down. See this? The tumor has been brought down and it has a small attachment here in the roof. See this? See this? And
Yes, yeah.
I can remove this.
Wow.
The medial component is out without any issue. See this? Can you see the medial component of the tumor?
Yes, we can.
And what it has given us? It has given us the space to accommodate the lateral component now. Got my point?
Yes, yeah. So we can
That's why
have a much better
this was
access
a
in the view.
strategy to divide it back. Now, for the mucosal ooze, I'll pack for a minute or two. And then we'll start removing the lateral component to various areas. Various difficult looking areas. And believe me, it is a cakewalk now with this kind of exposure and space in the nasal cavity and nasopharynx. It will come out like a cakewalk. In next 10 minutes, we'll be through. See now the medial part of the tumor has been removed. Things are under control. See the visualization. And I hope you are all oriented.
Beautiful. Yes, beautiful. I mean, this is modified Denker's approach. You can see the very large
That's the
maxillary
beauty of the
sinus
Denker's
cavity.
approach.
Yeah.
That's the beauty of
Right
this
from-
approach,
Yeah.
that it gives opportunity to visualize head on everything. Approach head on everything. One girl. See this? So this is for a couple of minutes to make the feel good. And now we'll embark on the lateral component. We have seen we have a huge component in the infratemporal fossa. Superiorly, inferiorly, anteriorly, posteriorly, everywhere. And from there only, it is going in the inferior orbital fissure, superior orbital fissure, and then in the cavernous sinus, which we have to pull it in our next couple of minutes. That's it. So our major part of, surgery has been done, which is done with the exposure. See the medial component removal, it didn't take more than 5 minutes.
Yeah. It's very swift. Not
How
much
is the
bleeding as
feel?
well.
How do you see the
Feel
feel
good.
now?
Field was brilliant. I mean, now the bleeding has virtually stopped. Even during the removal, there was hardly any bleeding.
Just a minute or two. I will improve the field and then we'll go with the tumor removal of the lateral part. The biggest tumor is in the lateral component, and you will find this is easiest to remove as compared to the, what it was looking like. Any questions meantime?
I think we're good. I mean, you've explained everything very thoroughly. We've gone as per the strategy, and it has worked very much as planned. So we divided the medial component, lateral component, and anatomy at display is fantastic. Let's see the whole maxillary sinus very widely open, right from the roof of the sinus cavity to the floor. It's very flush with the nasal floor. Then the posterior wall is open. The IMAX have been secured, and now the lateral component of the tumor is there. And Dr. Satish is carrying on with the strategy of surface coagulation using the coagulation. So it's a surface coagulation really, because the blood supply of the tumor essentially is all along the surface. And as Dr. Satish explained, as the tumor grows, the central part of the tumor tends to be a necrosed one, and the periphery is vascular. Yeah.
Now, we go ahead with the tumor removal from the lateral part. And the strategy, I told you, it has gone everywhere. We have to pull it out. So it's a sort of traction and counter traction, which is going to be the strategy. Now see, we catch the part of the tumor and then we'll keep advancing our instruments. Yes. See this? Catching the part of the tumor. Can you see?
Yes. Yeah.
This doesn't invade the muscle. It prolapses, goes beyond. It doesn't invade. See the tumor surface. We keep advancing your instrument. See this?
Yes.
This is V2 which I am separating. See, keep advancing your pull to get the tumor. See this?
Yes.
And see, this is my traction and counter traction with the oblator. See, just to show you.
We seem to have lost the video. So while the video is connecting, so what do you think of it, Lewis? Sorry, you're muted.
Sorry, I was on mute there, Ashok. I think what's really interesting is the fact that the patient has not had preoperative embolization, but yet with this technique where you do the surface coagulation, you then find the internal maxillary artery, the field is virtually bloodless. And I think that's, you know, the JNA is quite anxiety provoking because of the vascularity, but actually you can see how you can achieve a bloodless field in clean dissection, you know, with this technique.
And this is even without any embolization. So that's really incredible.
That's right.
I think we're seeing all through these 3 days, we're seeing a very common link here. So the surgical procedures, all these master surgeons, although the pathologies are extensive, they can be quite scary into very difficult areas. But what they have done is broken down into different small mini procedures, to say, like modules, as you said yesterday. And then addressing that individual component, they all come together to become that surgical procedure. So just looking into the details of it, nitty-gritty, and having a strategy in place to deal with that particular part of the surgery. Yeah, so there's a fine example here where we're witnessing how he very carefully analyzed the blood supply, the vascularity of the tumor, and each part he had a different strategy.
Hello. Hello.
So we're back.
Hello, Dr. Okada. Hello.
Hello.
Are you with me?
Yeah, yes, we lost a picture for a minute or so, but we're back now.
We can somehow disconnected, but now, see now, the entire tumor being pulled, all the lobulation of the tumors are being pulled. Can you see very carefully?
Yes.
Very clear?
Yes.
See, the traction and counter traction is the key. Yeah, hold, advance. See this? The hold is and advanced. And more deeper tumor being pulled off. See this?
Yes.
See how
Wow,
big
what a
tumor
discovery.
it
Wow,
is.
that's amazing.
Wow.
See how big this tumor is. Yeah. I told you the end will find some bleeding from the middle meningeal behind. See
Mhm.
this?
Yes.
Yes.
See this coming from behind. See our vessels which we have clipped. And see this
Yes.
bleeding. This is mainly coming from behind. Give me a gauge, please. See this bleeding?
Yes.
Because there was a vessel coming from behind. See very clear? And some more vessel which I am
Yes,
coagulating
sir.
here.
Yeah, you can see the vessel very clearly. Beautiful.
See the entire infratemporal fossa is empty now of the tumor. Oh, sorry.
You can see how the internal maxillary artery has gone almost back into place, having been stretched around the tumor.
This is the vessel which is coming from above.
Mm-hmm.
See this? See, there's a vessel which is coming from above, and we'll tackle it later after the tumor removal. Meantime, we'll just put a small piece of Surgicel over it and pack. See this? Can you see that beyond the tumor it is? Hello?
Hello, yes, yeah. We're behind
This
the
is beyond the tumor. The entire tumor has been pulled medially. इसीलिए कहता हूँ यही देते गॉड बड़ा. See this? We'll just pack it. This vessel I told you on the scan, we have to face it. And we'll control in no time without any issues. See this?
Mm-hmm.
Later on, we'll most likely clip it or coagulate it. Not now. Right now, our goal is to remove the tumor first. See this? All
Yes.
lateral tumor has
Yes.
come in the medial part. See this? See this?
Yes.
See? See this? All tumor everywhere. Section. See everywhere?
Yes, sir.
Yes.
Now, see this. This tumor is going in the fissure. Can you see this?
Uh-huh.
This is the last component which is going toward the cavernous sinus here. See this? And I will
Yes, sir.
gently pull it off. And you will see the gush of venous bleeding after that.
Mm-hmm.
That will be healthy bleeding. You put it niche kar. Now, see now how gently you have to pull it off. See this component close up. Can you see?
Yes.
Look at
So
my
that's
pull.
the section that was going back
Just look
to.
at my pull. Look at my pull.
Wow.
Keep advancing. Gentle pull. It will not break. This is from the supraorbital fissure, and
Orbital
this
fissure.
last component is coming from the cavernous sinus. See this?
Yeah. Yeah.
Yes. See this last component coming out. This last component coming out of cavernous sinus. This one. अरे यार छूट रहा है. छूट रहा है यार. WhatsApp दे दूँ. See this last component which is coming out of the I'll remove this part of the bone. See this component? Keep an eye on it.
Yes.
Keep an eye on it. पकड़ने वाली देना एक। Flux दे दे। See this last component which is coming out.
Yes.
This is true cavernous sinus component. And see the venous bleeding afterwards. See, it has come out one piece
Wow.
One piece. Wow.
from the cavernous sinus, and see this cavernous sinus from inside. See the venous bleeding.
Yeah.
Yeah.
Artery section. See the venous bleed. Can you see?
Yes.
Yes.
Yeah.
This is healthy bleed. I am not keen to pack it tightly here. See, the entire tumor is out within the nasal cavity. And now I will push it, since it is too big. No. Since it is too big, this should be pushed through the oropharynx. And there is a pack. First, let's move the pack from behind. This pack. For that, we can push our tumor behind now. See this? Huge tumor. Huge tumor going down. Wait. See this? Yeah. See the V2 there up. Separated. I am not packing the cavernous bleeding so far. All packs removed. Wash. Just let me show you. All packs removed. I want this little bit of venous bleeding to come. Ensure that no tumor is left behind. See the cavernous sinus from inside. Can you see the cavernous sinus?
Yes. Yes. So venous ooze.
This is cavernous sinus. This is sphenoid sinus. And see the pulsations of the carotid artery. See the carotid pulsations.
Yes.
Can you?
Yes. 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 We can see it very clearly.
So now I will
planning to
leave
use any
a small
flow seal here?
Surgicel. Give me a small
Surgicel.
Surgicel. See entire tumor out.
That's
Lateral
incredible.
component.
Yes,
See V2 which is running all the way in the roof. Can you see this?
Yes. Yeah.
Yes.
This is the cavernous component. And I will place some Surgicel into it without pressure.
That's amazing. And all done with the medial wall of the cavernous sinus remaining
Without
intact.
pressure. See, I am not using any pressure at all. There are lots of nerve running through the cavernous sinus and you are not supposed to pack tightly. Okay? I am just leaving the Surgicel and putting a pack over it so it doesn't come out. See this? With no pressure at all. Shoulder. See this? Let some blood come out, doesn't matter. It will stop automatically. See this? And now this tumor which is released. See, it is completely released out. See the tumor which is completely released. See the tumor completely free? Hello?
Yes. Yeah. Yes. We can see that. Yep. All along the floor.
Nasal cavity, sphenoid sinus, suction in this sphenoid sinus, the pack towards the cavernous sinus and pack towards the infratemporal fossa. All clear?
Yes. Yeah.
Yes.
To see
We
all
will
the
push-
landmarks in.
We will push this, tumor, push this tumor in the oral cavity. and remove from there. Now, see this? See this? This has
Yeah.
been
Yes.
pushed. A pack in the nose meantime for a while. A gentle pack. Keep the feel good. See the nasal pack? No bleeding otherwise. We have pushed the tumor down and then we'll remove the tumor per oral. So lateral component didn't take more than 10 minutes, I told you. Look now. Suction kar. See, this is the tumor which is coming out of the oral cavity. Can you see?
Yes.
Yes.
Yeah.
Various components of the
Yes,
tumor. Various components. This was the cavernous component. This was the infratemporal fossa. See this all component. All components of the tumor. And this was earlier the medial part of the tumor. This tumor was like that. So we divided it here at the medial part. See this?
Yes.
This was separated earlier. This was going up in the cavernous. This was going in the infratemporal fossa. The entire tumor. Can you see very clear?
Yes.
Yes.
Now, let's check the pterygoids. Let's check thing. Let's check the vessel. See now everything under control.
Yeah, it's amazing. There's hardly any bleeding, isn't it?
It is the axis
Very
which
minimal.
matters. It is the axis which matters. ये देखो मेरा, ये देखो. This is the part where we cell. Can you see?
Yes.
Yeah. This is pterygoid venous oozing outside, which starts with the packing. You don't need to really do anything much. एक वो रखना, forceps or clip. Now this was the vessel which was coming from behind and showed you an MRI as well, which was supposed to avert from tumor removal. See, these are our vessels which we clipped earlier. Can you see? Yeah, and see we pattern everything under control. Give me cobbletter. So I want to coblet that vessel area. See, this is all infratemporal fossa. See how the infratemporal fossa bleeding control with the coagulation.
Yes.
Now this is vidian canal, which I am going to drill off later. See this one. This is vidian canal. This is
That's a common
V2
site of
going up in the
President.
foramen rotundum. Hello.
Yes. Yeah.
This is V2 going in the foramen rotundum. See above. This is the eye. This is the serpentine course of the V2 in the roof. See this?
Yeah,
Yes.
you traced it all along.
This is cavernous sinus. This is here going to be the foramen rotundum region. This is all pterygoid process which was having the tumor. See, this tumor was here, which ultimately we have to ensure a microscopic clearance. Now, give me some Surgicel. For the infratemporal fossa now. See, entire infratemporal fossa very clear.
Yes. Yeah. Lovely.
Now I will pack because this muscle surface can ooze. So Surgicel one more.
So vidian canal tends to be one of the common site of residual disease, isn't it? So
Very
planning
good.
to drill around the canal.
See this? Just leave. Now, this bone is the notorious bone, which is often invaded by the tumor. Very good. Now see, this is the region of the vidian canal. Can you see the vidian now?
Yes.
Yes.
See how it is destroyed. Can you see?
Mhm.
This bone is a cancellous bone and often invaded by the tumor. First, let's work that. The nerve transected, whatever soft tissue there, and we have to ensure this cancellous bone is tumor free. So I will use my special drill for that. Again, high speed diamond drill. Canal with suction. Wash करके suction करो. See how the normal bone bringing out. Can you see?
Yes.
All this cancellous bone has to be now. See this entire pterygoid process all around the V2 and vidian. So-called recurrence. दिखाते रहो. Section रख. Wash. Give me a wash. Just wash. Dharma. Or wash that number one. Wash, chapter wash. मन पड़ा है आगे से. मन पड़ा आगे से. Give me a wash. Hello?
Hello?
This is fine tuning now to ensure that no abnormal bone is left behind.
Minimizing the
Finish.
chances of recurrence, really.
Yes. Just finishing. See the edges of the cavernous sinus opening. See the V2. Now see each and every area close up. दूर रखने को बहुत बड़ा है. See now, this is cavernous sinus region with Serge cell. See the two बीमारी है तुम्हारी. बोले तू हले बोले पतला ले यार. Yeah, again see the close up. Now see the pterygoid bone. Can you see?
Yes. Yeah.
The cancellous bone. Can you see very clearly? This is V2 where the foramen rotundum is. Where this infraorbital nerve is going in. Can you see this very clear?
Yes.
See the pterygoid below. Pterygoid has been
Very good.
drilled off and flushed. See this is thin bone is left behind. See the pterygoid. This is vidian canal where the vidian nerve sacrificed, cut and flushed. Everywhere there is no tumor. Can you see now?
Yes. Yeah. Agree.
Yes.
This is
This
the
was nicely
advantage of
clear.
endoscopy. This is the advantage
Very
of
clear.
endoscopy. You can to find crevices, canal, foramens. This is the biggest advantage of endoscopy, which is called open surgery. It is not that the scar which matters. The entire cancellous bone has to be thoroughly cleaned off. Now I can say that no tumor. See this? See, look at the pterygoid.
Yeah.
No
Very
tumor
handy
has
now.
been left behind. Can you see?
Yeah.
Mhm.
I think that's the
That's
key
the
to minimize the
pterygoid.
recurrence. Yeah.
That's the pterygoid. That's the palatovaginal canal containing the pharyngeal nerve. See that?
Mhm.
Wait. T2, and this is the cavernous sinus. This is sphenoid sinus. So all this area, this is infratemporal fossa, see your internal maxillary clip there. And this is by V2. See this? This is infratemporal fossa. This is your nasopharynx. See your, चल ही नहीं रहा, बंद है. See your, see both the eustachian and tube orifices. This is adenoid surface. Never takes attachment on the adenoid surface. See this? Can you see? Very clear?
Yes. Yes.
Yes.
Yeah.
Just when I will finally close with some Surgicel, some nasal pack for a day or two. So that's all about the pack. That's all about the endoscopic, excision of juvenile nasopharyngeal angiofibroma with the all named extensions. इधर ले आओ, कुछ cut कर दो. Any questions, any suggestions so far?
No, that was wonderful. It's a great technique, removing the whole tumor, minimal bleeding. That was quite astonishing, wasn't it? With that size of the tumor, with that vascularity, without any embolization, very minimal bleeding. So
Volume बढ़ाओ ना इसका कहाँ है?
brilliant.
I need a picture.
The technique used makes it look straightforward and simple, but it's anything but.
Yeah, absolutely. You need to know about your anatomy, where exactly you are, where the vessels are located, and individual vascularity of that particular area, and having a strategy to deal with it. We saw the use of coblation, use of Liga clips, use of bipolar, and dissection. Often use the coblation wand as a dissector and very selective coblation at the same time.
I think as well, having the confidence to just gently pull the tumor that was in the cavernous sinus.
Yeah.
You know, just patience and just that sort of gentle pressure to bring it out. And it's quite amazing seeing it coming out all in one piece, isn't it, on block?
Correct. Apart from this central division, the rest everything will kind of fall in place.
Yes.
See, with this kind of situation, there is always a question regarding indications for open approach. See, in this case, there was no indication for open approach. The reason was imaging guided us where exactly the tumor is extending to, what are the crucial areas where the tumor is going to, whether there is any intracranial major vessels supplying to the tumor which can create problem, which makes you think for an open approach, which was not in this given case. So it is not the, extension, it is not the size of the tumor which matters for the indication. Indications now in this era are well defined, and due to, progress in the endoscopic approach, more understanding of the anatomy with equipments, coblation, cameras, high-speed drill, it has more and more become, easier to approach the tumor endoscopically with distinct advantage. The way we, defined all the canals and drilled away the pterygoid is not possible so easily in the open approach. In the open approach, you remove the tumor in one go and pack because of the bleeding, and you don't have any opportunity to inspect into those critical areas. So it's not about the, the fear of bleeding, makes the surgeons to choose the open approach. So you have to apply the strategy to control bleeding. Coblation was one of them. Catching the vessel prior to tumor removal was another. And using Surgicel packs, adrenaline packs, anesthesia, all those things ultimately contribute to overall reduced bleeding without even embolization.
Yes.
Sometimes, I don't know about the UK and US, but in our country, and I think it's everywhere, the cost of embolization sometimes exceeds the cost of surgery. It's on disadvantages. No embolization is safe. Though embolization techniques have improved, the experience of the intervention radiologists matter. The cost is the biggest factor. And, in such tumors, there are frequently, you will find on DSA, dangerous anasmosis between external and internal carotid system, which an intervention radiologist by experience can avoid your material extending into internal system. Otherwise, it can be very, very difficult. So, looking at all the aspects in the present scenario, in the primary setting, over 98% of the JNAs can be or extirpated better by the endoscopic approach with distinct advantage. Forget about the scar, which is the least of the advantage. I would enumerate. The advantages are obvious, we discussed throughout. And this is why this is the preferred approach. And we have a large series now, over 400 something cases with major JNAs. We have been able to remove without embolization and majority without even transfusion. So this is how you have to, plan our strategy for JNA. Any questions, Dr. Ukade? Any more?
This case is a fine example of that, what we witnessed today. I mean, if you can manage the surgery with such a minimal bleeding, it's probably bleeding very comparable to a tonsillectomy bleeding. Not even that, I would say. So if you can manage it without embolization, then definitely why take all the risk of embolization? It avoids altogether. So there's a distinct advantage. And as me and Luis were discussing when there was a break, that breaking down the surgery, complex surgery, into different components, and then having a assigned strategy to that component, that makes the surgery really safe and possible, even though at the outset it looks very huge tumor complex surgery. So you have demonstrated that very, very nicely. And thorough study of the imaging, again, what you have shown this morning, that underlines how surgeons should be approaching the imaging studies and looking at the pathology and the anatomy very carefully. And that goes a long way, spending that time in planning your surgical strategies.
See, the science of endoscopic surgery is growing like anything. I think probably the fastest growing science in the medical specialty, entire medical science. And now, with the better understanding of anatomy, equipments, and all those, boundaries are unlimited. Earlier, I remember my training with Dr. Dharamveer Sethi from Singapore, who was the, magician for endoscopic sinus surgery, but still is. And amazing the way he displayed the anatomy and demonstrated and taught. It was amazing. Then the science grown further. Now, in the present context, I would say boundaries unlimited. Earlier, it was in 70s when Messerklinder and Stamberger did the research work. It was indicated or, developed for treatment of inflammatory disease of the paranasal sinuses with minimal work.
Correct.
Just open up the sinuses for ventilation and drainage, that's it. And now see how the application or the indications have expanded. See now, not only for the inflammatory, for tumor, not only for paranasal sinuses, but even beyond. Surrounding areas, infratemporal, parapharyngeal, pterygopalatine, orbit, everywhere you can, introduce endoscope and remove under vision. Then, not only for the skull base, even for the pure intracranial lesions, this is the preferred approach for distinct advantages. And I believe this science is going to grow further with the advancement in the technology, now with the lasers, now with the, this robotic surgery, now with the cobbler being incorporated with the other tools to go high up skull base, intracranial, and lasers being incorporated, so many things, the way it has a dynamic image guided system. So this is going to go next level in the coming times. So thank you very much for your attention for this.
Thank you.
And we are going for the next session. We have a couple of cases lined up, I told you. So we'll begin with again with a pediatric case, adenoidectomy, as we discussed earlier, and for some reason, how the surgery, how can we use judiciously this coagulation and microdebrider to improve the outcome of adenoidectomy. Reducing the complication and improving the outcome is the goal. So that is one. Then we have in row some sinus surgery, primary, revisions, CSF leak, as time permits till 3 o'clock Indian Standard Time. So before you go to adenoidectomy, anything else, Dr. Ukade?
No, that's thank you. There's a really great demonstration. So do you have any break for that, 5-minute break before we start the adenoidectomy?
Adenoidectomy, I tell you, has many indications. Primarily, it is used for obstructive reasons. Means children who are mouth breather, the nasopharynx is choked because of the adenoids, forced to breathe through the mouth, having its own complications on the facial structure, on the, other things. So in our institution, in our setting, what we believe, we have three major indications for adenoidectomy. And surprisingly for everybody, the obstructive indications are less. In true sense, adenoidectomy in our setting has three indications. One for obstructive, as we discussed, this is the commonest everywhere, when the adenoids are enlarged, blocking nasopharynx, child mouth breather, and you have to remove it. The other two indications are for chronic rhinosinusitis in children, which is not getting controlled with a maximal medical treatment, where adenoid becomes the source of infection to the paranasal sinuses, and it has been proven by various regions, microbiologically, by other regions, it has been proven. And once in children, the CRS doesn't come under control, and once you think of surgery, adenoidectomy is the first surgical procedure one should take up. And majority of the time, such medically uncontrolled pediatric CRS with adenoidectomy done, where the adenoidectomy happens to harbor the biofilms, and once it is cleared, majority of the CRS, pediatric CRS patient, in those you can avoid a formal sinus surgery. Not all, but in majority. Because the formal sinus surgery in pediatric patient is challenging for various reasons, we all know. Anatomically, working in the narrow areas, and then post-operatively douching, which is the mainstay of treatment, for the future, is not so, easily possible and, responded by the pediatric patient. So, you have to do all possible measures to avoid a formal sinus surgery in pediatric, except for some straightforward indications. So that is a non-obstructive indication for adenoidectomy. The reason being, the adenoids are not enlarged enough to obstruct the nasopharynx, yet becoming the major source of problem, giving CRS to the pediatric patient. Got my point? This is one major non-obstructive indication. Second, adenoids not large enough to obstruct the eustachian and giving oral complication. Yet adenoid is the source of problems for the recurrent otitis media. And in both the settings, still adenoidectomy has a big role. And believe me, these two non-obstructive indications are overlooked everywhere. And medial adenoidectomy at many of the centers in the world are solely indicated for obstructive indications. So, in our opinion, there are three indications, two non-obstructive and one obstructive, where the adenoidectomy is indicated. Once it comes to adenoidectomy, again, adenoid is what? It is simply a lymphoid tissue which is hypertrophied in response to ongoing allergy and inflammation, infection, whatever. See, whatever environmental, pollutants, microorganisms, toxins, whatever we inhale, ultimately expelled by our mucociliary system in the nasopharynx and then to the gut, and they are exposed to the adenoid surface as well. Those who are allergic in response to those stimulants, the adenoid can get hypertrophied. In the adenoid crypts, then the cytokines can accumulate and becomes a source of problem. So it's a sort of vicious cycle. The allergy and infection can aggravate the adenoid hypertrophy, and the hypertrophic adenoid can aggravate the ongoing allergy and infection further by means of blocking the mucociliary activity. Got my point? So in both the situation, the adenoidectomy has a major role. And once it comes to adenoidectomy, it requires a comprehensive removal. It's not a tumor. Many a time patient or even surgeon talk about the recurrences of adenoid. See, it's not a tumor. It's a hypertrophic lymphoid tissue with response to allergy and ongoing inflammation and infection. So similarly, you have to comprehensively remove the hypertrophic tissue without giving complication there to the surroundings. And at the same time, you have to focus on the treatment of allergy and infection, inflammation, whatever going on. If simply adenoidectomy is done and not, further followed with the treatment of allergy and infection and all that, it can come back. It's a body's physiological system, part of the immune system, to respond by lymphoid hypertrophy to the such allergic inflammation and infective challenges. So it is bound to come back. So in all these patients, we have to have a solid workup. It's not about the adenoid hypertrophy, which is you see by the X-ray and, advise the surgery. The child or the children has to be thoroughly worked up for immune disorders, immune deficiencies, allergies, and source of respiratory infections. If those not assessed, if those not addressed post-operatively, the entire exercise can go waste. So our philosophy requires a thorough workup of all these disorders before you take up any child for adenoidectomy. For allergy, infection, and immune disorders, which are not uncommon in children. The children immunity is always, in majority are on the lower side, precipitating recurrent, infections, inflammations. So those part has to be thoroughly worked up medically. And in the post-operative period, you have to keep a close watch and address those issues post-operatively. If allergies remains untreated post-op, it can again lead to adenoid hypertrophy, which is the principal reason behind the adenoid hypertrophy. So the counseling should involve surgery as a part of treatment and rest of the medical treatment as a core treatment. Got my point? We cannot say that
Yes.
the child, once you do the adenoidectomy and the child will be cured. It cannot be. It's a joke. You have to treat the conditions associated with the adenoid hypertrophy and follow them, watch them closely and treat them post-operatively, particularly allergy and immunity. So once it comes to surgical part, see, adenoidectomy has been traditionally been done by various techniques. We have seen, I have not seen personally, but heard in the past with the adenoid curate position. Adenoid curate blindly, then with many other instruments blindly, then the endoscope introduced and adenoids removed with a microdebrider, adenoid removed with a cautery, adenoid removed with a harmonic scalpel, adenoid removed with a coagulator, and there is always a confusion which technique is best. So this demonstration involves the critical discussion of use of various techniques of adenoidectomy. So this involves the discussion of the use of coagulation and microdebrider judiciously together to optimize the outcome, and how to comprehensively remove the adenoids. If you leave the adenoid partially behind and with the ongoing allergy, it is going to come back. This is for sure. A lot of patients come to us that we had got adenoidectomy done and it has come back. Will it come back, doctor? So it's not a tumor. It's not going to come back. You have to treat associated conditions and a comprehensive removal. So in this surgical technique, we are going to show you our technique of comprehensive adenoidectomy for once and for all. There is no question of a revision adenoidectomy exists. No question even exists. So this is how we are going to do it and follow further with the treatment of allergy and inflammation. So in couple of minutes, the case is ready. This patient had tonsillar hypertrophy as well, which has been done by my colleague, Dr. Ajay. And so I am going to show adenoidectomy only, not the tonsillectomy one. So any questions
Dr.
before
Satish,
that?
there is a question from juniors that there is always a very rarity that scares the juniors though regularly. It's about the aberrant internal carotid artery when you're doing the adenoidectomy. What really is the incidence and how much the junior should be really worried about it? Because that stops many of them to do the thorough adenoidectomy.
Regarding the adenoid?
The aberrant blood vessels supplied to the adenoids from the internal carotid.
I didn't get your question. Can you repeat, please?
Any aberrant blood vessel supply to the adenoids.
Blood vessels. See, that I will.
The juniors.
I will mention. See, as such, there are no big vessels supplying the adenoid tissue. Adenoid is situated on the perimysium of the nasopharyngeal muscles, nasopharyngeal musculature. We see in the nasopharynx, in the posterior wall of the nasopharynx, posterior superior wall of the nasopharynx, are a couple of muscles. On the longus colli, longissimus capitis, rectus capitis, laterally, are the number of muscles forming the nasopharyngeal, architecture. And those muscles are covered by the perimysium. And adenoid as a lymphoid tissue is situated over the perimysium and goes laterally over the muscle and behind even the Eustachian tube into the fossa of Rosenmuller. This is where the adenoid extends. So as such, adenoids are not innervated or supplied by any major vessel. We'll show you our technique. Definitely there are, being a live tissue, there is blood supply, but not so significant named blood vessel going to the adenoids. That's why this technique, what we are going to show, is actually we discovered and we propagate as a technique to comprehensively remove without damaging anything all around. See, all around there are lots of structure in the nasopharynx. There is Eustachian tube, there are muscles behind, there are far laterally even the carotid artery. There are so many structures all around the nasopharynx. And soft palate below. So this technique involves protection of all these structures wherein the adenoidectomy is done under vision. Only the removal of adenoid is the goal, not damaging anything outside. Now, if the soft palate is damaged, the complication, implications in the past, in the future, even with the voice change, nasal twang. If the nasopharyngeal musculature is damaged, can lead to cicatrization, nasopharyngeal stenosis, and nasal twang. If Eustachian tube is damaged, we know the oral complications, and so on. So we have to preserve all around everything under vision, under endoscopic visualization, and all the surrounding structures are preserved, and these two tools, the oblator and microdebrider, use sequentially to identify the plane and preserve it. This may incur little extra bleeding, but it helps us identifying the plane properly, which I'm going to show you. Any other question before we go, or do we go ahead with the surgical part?
Yes, please. Thank you.
Okay, we can continue discussion there. And after this case, we'll be taking up a case of primary sinus surgery, then revision sinus surgery, and then CSF. Yes. Okay, thank you. Great. So we'll be back with the endoscopic picture in a couple of minutes.
Sure.
ये वाला दूसरा जिसका आपको सिक्की देखना था। नहीं मैंने जो देखा था वो लेना है। बुला लेता हूँ। हाँ। ये उसके बाद। ये उसके बाद।
My name is Dr. Abib Agbatova. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant synechiae formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and synechiae formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft tube B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was noted to have minimal edema, no synechiae formation, and minimal crusting. The contour propel stent
That's us moved back to your theatre now.
Hello.
Hello.
Hello, am I audible?
Yes.
Are you getting any endoscopic picture now?
Yes, we are. It's very clear.
Okay, so I told you there's a young child where I'm going to demonstrate you adenoidectomy. A
Yes.
tonsillectomy has been done by our colleague, you can see here.
Okay.
And I'm going to show you adenoidectomy. This is the right side nasal cavity, which I'm decongesting with the saline and adrenaline swabs. You see there, to open up the nasal space so I can negotiate my, telescope. Children with a narrow nasal space is sometimes, again makes it more challenging. And many a times in the young children with the too narrow spaces, we have to resort to finer 2.8 mm endoscopes. But majority with good decongestion, we can negotiate our 4 mm endoscopes and carry out the sinus, this adenoidectomy. So I'm using these adrenaline, straps. See this?
Yes.
To open up the nasal space to go behind.
Yes. And has this child had pre-operative imaging?
X-ray?
No, in any imaging, like a CT scan or anything. Do you do that
No, we
routinely?
did just X-ray, just X-ray.
Just X-ray.
Yeah, we did endoscopy and X-ray only.
Okay.
You can do endoscopy in these children with a fiber optic to see
Yes.
the adenoids. Still see the nasal space is so narrow.
Yes.
So you have to use these adrenaline straps to open up maximum possible without nasal trauma. That is very important. The nasal trauma can invite crusting, and in children, you can't expect the douching in the post-op so judiciously.
That's right.
I'm trying to open up the space to negotiate my endoscope.
And do you vary the concentration of topical adrenaline that you use in
Yes.
children in comparison
Yes.
to adults?
1 is to children, in adults 1 is to.
Mhm.
See now the adenoids in the nasopharynx.
Yes.
This is after
Yes.
decongestion, completely obliterating the space.
Mhm.
This is from the right side. See, after the decongestion, we have been able to negotiate the scope and see. Then on the left side, again, see the adenoids in the nasopharynx.
Yes.
See this?
Yes, you can-
Completely
yes,
occupying,
yes.
completely occupying, grade 4 adenoids, you can say. So now, as far as the surgical part is concerned, my surgery will be, done in 3 phases, 3 steps. My number 1 step would be with using the micro debrider with little bit bleeding acceptable, a fast phase to remove the luminal adenoid, luminal clearance. Whatever adenoid you see in the lumen, obliterating the nasal space, will remove it. Gross removal is the first step. Okay?
Okay.
So what I am doing, find out. I am using my red 60 sinus blade from behind. See this? Find out.
Ah, yes. Okay. So you've come in transorally.
Yeah, transoral. This red 60 blade transoral, not the adenoid blade. See this red 60.
Yes. Yes.
Now this first step involves first removal of the luminal adenoids to open up the nasal space as fast as possible, because this will involve a little bleeding as well.
Yes.
I am not using coagulator here for the reasons I will tell you. So here, this technique in bleeding except bleed to रखता है. Malpando. Can you see that?
Yes. So you've very quickly taken a lot of the bulk away.
Yeah, so this is bulk removal.
Mm-hmm.
This is stage 1. And see, under vision, both the USEC and tubes are spared from
Yes.
injury. So this is quick phase within a minute. Remove it, and I will pack from behind. See this? Now the airway is opened up.
Yes.
So this phase is to open up the airway and pack with the same saline adrenaline
Mm-hmm.
gauze piece, just for couple of seconds to apply adrenaline on the surface. Just for a couple of seconds,
Mm-hmm.
so that it will decongest and minimize the bleeding. See this?
Yes.
The gauze in the nasopharynx pressing on the raw area. Very narrow nasal spaces.
Mm-hmm.
Still I am able to negotiate my 4 mm telescope. See the pack behind. So this first phase is not very crucial. It's involved the luminal clearance. Okay.
Yes.
Now my next phase starts. Funny. I will remove this pack. See, I have removed the pack. See, I have removed the pack.
Yes.
And now my second phase involves complete removal of the adenoid in the plane.
Okay.
Can you see the mucosal plane below?
Yes. Yes, the normal mucosa, yes.
Yes. This is the mucosal plane and this is all elevated tissue is all adenoids.
Yes.
Second phase again I am doing with the microdebridor.
Okay.
The reason being, if I use the coblation, I can test the underlying muscle and perimysium,
Yes. Okay.
which I don't want. So
No.
see here, with this front facing blade, see this?
Yes.
I am, see the cutting edge is towards me, not behind.
Yes.
And
It's
see this,
facing
I am elevating, removing this
causally.
adenoid, which is
Plainly.
above the plane. Can you see?
Yes.
What I am preserving with the shaft of the blade, preserving the perimysium behind.
Mm-hmm.
The sheath covering the muscle is called perimysium. Can you see the surface behind?
Yes. Yes, you can
Yes,
see
yes.
that. Yeah, it's a nice plane.
See, the muscle covering is intact.
Yes.
That means muscles are spared. That means muscles are spared. If I use my coblation, it will invariably char the muscle
Yes.
covering and muscle. And I won't be able to differentiate between the adenoid and the muscles.
Yes.
I am purposely using microdebrider with little bleeding. See this?
Yes.
Now see, this is perimysium. Find out. See this muscle covering. And behind is the muscle, mobile muscle. See this?
Yes. Yes.
Now above, there is no muscle behind. This is basi-occiput. This is basi-occiput behind. See this?
Yes, you can see that.
Yes, yeah.
No muscle behind, above. So above I can remove the adenoid tissues like combing, hard combing. See this? No muscle behind to damage anything. See this?
Yes.
Yeah.
Only the periosteum is there and see my hard combing. Since there is no muscle, I am not bothered about damaging anything behind. See, this is basi-occiput only covered by the,
Yes. Because you're right down on the periosteum as you go superiorly.
yes.
Yes.
See, this is hard combing.
Yes.
Below there was muscle, so I cannot be very aggressive. I have to stay on the perimysium.
Yes.
My point? But above, see, only periosteum now, no adenoids.
Mm-hmm.
See, this is all periosteum. I have done a sort of combing. See this? Removed in the plane. Again. Could you see?
Yes, yeah. It's very nice.
Yes, you can
Now,
see it. Yep.
This is
Right
my
down to periosteum.
second phase over. Can you see?
Yes.
Look at the plane. And now again after this phase, I will pack for a while. So far, it was all removal under vision and under plane. Will this bleeding with the microdebrider? I never use the coblation till now because I want to see the plane. Had I done with the coblation, so it would have charred invariably the underlying structures. Got my point?
Yes.
Yes.
Yeah.
Our goal is the removal of the adenoid, not charring the muscle or the perimysium. We have to preserve all. As long as the perimysium is intact, your muscle is preserved. If your muscle is charred, it can lead to even nasopharyngeal stenosis, which is most difficult to treat. See my pack again in place?
Yes.
So this was second phase. Just removal of the adenoid in the perimysial and the perimostial plane, in the midline, under vision, completely, comprehensively. Okay? And packed. But no adenoid tissue is left behind in the center. I will show you after pack removal. Below there is perimysium and above there is periosteum. Behind the perimysium is the muscles. But behind the periosteum, there is basiocciput, nothing else. So now again, wash. After a couple of seconds only, I'm removing the pack. See this goblet. See this?
Yes.
Now the pictures. Oh. See this? This is the perimysium, intact perimysium. See this?
Yes.
And as long as perimysium is intact, there is no bleeding there because the muscles are protected. Bleeding from the periosteum above. Perimysium, I don't want to char much. See this? It can,
Yes.
it is not wanted. But periosteum, won't excessively char it because no behind. Perimysium is behind, which can contract.
And is that the same coblator wand that you were using with the previous case?
Yes, the same.
Yes.
Same, different one, but same ProSize Max.
And what sort of angle is on that?
Yeah, angle I have bent it.
You bet. Ah, right. Okay. Okay. Perfect.
See now, I am purposely coagulating the periosteum. Purposely means so that no bleeding happens in this periosteum. The vessels in the periosteum cannot contract, but the muscle below can contract and stop bleeding. It is so above, wherever the basiocciput is, wherever the periosteum is exposed. See, I have purposely completely a sort of carpet coagulation. Can you see?
Yes.
This is purposeful carpet coagulation of the periosteum because periosteal vessels cannot contract. And it is safe because there is no muscle below. Can you see now?
Yes.
This is the perimysium which is intact. As long as perimysium is intact, there will be no bleeding. Can you see?
Yes.
There cannot be any bleeding in the perimysium because the muscle is protected from behind. And now see, above the is purposely coagulated. Secondary hemorrhages in the adenoid surgery are from the periosteal area because there are no muscles there to contract. But my point, so this area should be purposely coagulated. See this? Periosteal
Yes.
is purposely coagulated. No question of bleeding coming from there now. Okay?
Yes.
And this is the mucosa for the oropharynx. This is the perimysium of the nasopharynx. No bleeding at all. Now, this is second phase. Still, my adenoidectomy is not complete because I have extensive adenoid. See this behind the torus.
Yes.
Can you see?
You can see.
See behind the torus.
Yes.
Laterally
Still quite a lot of
hypertrophic
tissue.
adenoid. Yeah. This laterally hypertrophic adenoid tissue can contribute to oral issues. So now the third phase is remove laterally hypertrophic adenoids. See this?
Yes.
I am not using coagulator to give unnecessarily charring. I am using my adenoid blade. See this?
Yes.
Front facing blade. The rear part of the blade to protect the perimysium. See this? So we'll press on the muscle and allow the adenoid tissue to fall in the blade. See this? See massive adenoids. One can overlook. See this? I am
Yes.
doing any blind. I am not pushing the blade blindly. See this? Pressing on the
Yes.
muscle. Pressing on the muscle and all soft adenoid tissue is falling into the blade automatically. See this?
Yes.
Only the adenoid, nothing else. You can find some bleeding which will be controlled without any problem. I am just staying on the muscular surface. See this?
Yes.
See, the underlying muscle is protected with the blade,
Yes.
with the blunt surface of the blade. And
Now, say
see, only the soft adenoid tissue has fallen inside. It's cleared.
yes.
And now,
What about if you didn't have access to a coblation system? Would you
if I use
suggest
the
this technique?
coblation, if I use the coblation, it would unnecessarily char all the muscles. See now, the entire fossa is clear. Because only the soft tissue will fall from distance into the blade. See this entire fossa.
Mhm.
See this entire fossa of Rosenmuller.
Yes.
Can you see this? There is
Yes.
nothing,
Yes,
no
it's very
adenoid
clear.
tissue, only the muscle surface. So this bleeding will come under control in no time without any fear. See, if you leave this laterally hypertrophic adenoid, this is going to give problem. So I am now packing this lateral region with the same adrenaline gauze for a minute. See this? Give me another gauze. Wash kar do na. See this? A small gauze piece in the fossa of Rosenmuller. See how
Mhm.
deep the fossa is and how much the adenoid tissue is recruited from there. Which one can easily overlook. Can you see?
Yes, yeah.
Yes.
I'll just leave for a minute and this will all take care of everything.
Say you didn't have a coablator though. I'm just thinking about the hemostasis. So say you removed and debulked it using the RAD 60.
Yes.
What would you
Cobblator if I use for removal, see this, I would char all this surface, muscles, everything invariably.
No, sorry. What I mean was, if you don't have a coablator, what could you use? I was
Bipolar.
wondering about like the suction
Bipolar.
monopolar, but I was just concerned that the
Bipolar.
bipolar, yes, the monopolar would
See,
cause a lot of damage.
the beauty of the cobblator, it is always irrigated by the sunlight.
Yes, so the heat
So the
is not.
collateral temperature
Mhm.
is less. Temperature rise is less. So collateral tissue damage is less. Okay?
Yes.
See now I packed in the opposite fossa of Rosenmuller for a while. See this?
Yes, yeah.
This is for a while. We'll check later. Meantime,
Just
our
complete clearance.
other areas is clear and our fossa of Rosenmuller is crystal clear now. Now we'll remove the adenoid from the right side. See this? Find out. Now again. See now this side fossa of Rosenmuller. Can you see this?
Yes, yeah.
This is the torus. And again I blade point डालना ऊपर. डालना है करना. See again this all adenoid tissue which is otherwise left behind. See this? My blade is protecting the muscle. See carefully. क्या करते हैं? तो रोकना. See the bunch of adenoid tissue in fossa of Rosenmuller. Can you see?
Yes.
Yes.
Whose huge amount And see, under vision, your cutting edges should always be under vision. The blade is front facing, not the adenoid blade. We condemn using that. And just press on the muscle, gently allow the adenoid tissue to fall into the blade. See this? Only
Yes.
the soft adenoid will jump and fall into the blade. See this? Nothing else. See this?
Yes.
All clear. See my fossa Rosenmuller thoroughly. See the muscle behind. Everything clear. Idea is to judiciously use the cobblator and micro. I would never use the cobblator for adenoid removal, as it would invariably charge the surrounding structures. That is the biggest concern. Cobblator is for hemostasis at the end of the surgery, whenever required, only for hemostasis. I will show you now.
Dr. Satish, since you started your ENT career, I'm sure you must have gone through various techniques of doing adenoidectomy, right, from the blind curettage technique.
Yes.
So how do you find your evolution of adenoid surgery?
Yeah, the concern, there was a lot of concern. First of all, the visualization, which endoscope solved the issue. Then the tissue damage. The tissue damage, with a lot of patients coming with nasopharyngeal cicatrization, stenosis, nasal twang, all these problems, then adenoid tissue left behind giving problems. So all this tissue over the period of time, since we started using cobblator and microdebrider for other indications, it made us use for this particular surgery invariably, because these are children, these are, handle with care kind of patients, Now see, I have removed, my adenoidectomy is complete now. Now I will remove my pack from the lateral side and see how much adenoid need to be removed. See this. Can you see the lateral wall of the nasopharynx?
Yes.
Yes.
See the muscle.
Yeah, very clear.
Lot of people may raise concern over carotid artery injury and all that. Believe me, carotid artery is separated by layer of muscles from the nasopharynx. Here in the midline are the muscles, the longus colli and latissimus capitis. Laterally are the thick rectus capitis muscles. See now what I am doing. Just surface coagulation over the perimysium. Can you see the perimysium?
Yes, yeah, very clearly. Yeah.
Always preserve the perimysium. That's the goal. See now, no tissue, see far laterally. Because whatever adenoid, it has jumped into the blade. Only the soft tissue will jump. That's the beauty. Not the muscle or anything. See this? Now I'm using cobblator. Now I'm using cobblator selectively over the perimysium. Not over the muscle, not anywhere. That's how my avoiding the cobblator use everywhere for the fear of bleeding, allows you to char the unwanted tissue, that is perimysium and muscle, and give complication. Secondly, it doesn't allow you to, get to the plane easily. See now, it's comprehensive removal. You can see the various planes. This is perimysium, this is muscle behind the perimysium everywhere, and no adenoid at all. Can you see? The disadvantage of this technique, disadvantage is you have to get used to a concern or a little bit concern or 20 to 30 ml of bleeding. That's it. Which is justifiable with so many advantages. That is not going to give any problem.
And what settings do you use adenoids? The coblation, please. What settings do you use the coblation?
Same, pro-size max.
Oh, 5-9, same settings.
Pro-size max is the blade I use everywhere, no other blade. The advantage of this blade is the wide suction bore and a wide surface plate white surface plate to work upon with no other vent offers. See now, there is the pack in the right side, fossa rosum. See the fossa on the right side. See this?
Yes.
No adenoid is left. That's the beauty. Don't worry about the bleeding. See, as long as you don't damage the muscle, no bleeding will happen. All the vessels, major structures are beyond the muscle. Don't damage the muscle. Your blade will automatically protect you from entering deeper. Rather, blade is used to protect the muscle. That's why we condemn the adenoid blade, which is rear facing. See this? Everywhere.
Yes.
And lastly, 5 minutes, we'll wait for any bleeder or anything and we'll just irrigate. See the panoramic view of the nasopharynx with fossa of Rosenmuller on either side. See this? And this.
Yes.
And this is the final irrigation for couple of minutes. Continuous irrigation for couple of minutes to wash away any clot, to see if any bleeder comes. This is very important. See this? It gives you ample of time to look for any small bleeder you can coagulate. So no named vessel came like you asked, Dr. Okade.
Mm-hmm.
We did not damage eustachian tube, palate, the nasopharyngeal musculature, anything. It was all under vision. We purposely coagulated the periosteum, so no question of secondary. Okay?
And Dr. Satish, as you mentioning, it was not only the obstructive indication. It's quite clear that the obstruction will be taken care of, but it is also the biofilm that leads to CRS-related biofilm that will also be very nicely taken care of with this
comprehensive
technique. Yeah.
So this is comprehensive. No adenoid tissue is left behind. See the adenoid sitting on the muscle perimysium. Entire perimysium is intact. See nowhere is the adenoid. See this? The fossa of Rosenmuller, absolutely crystal clear till depth. See the fossa on this side. See the fossa on this side. You don't have to cross the muscular layer to give complication. So no fear of injuring any great vessel or anything. And this coagulation of this basioccipit perimysium is necessary to prevent secondary hemorrhage, because below here there is musculature where even if the bleeder comes, the muscle can contract and stop. But here there is no musculature. Bleeding from the periosteum is unstoppable, and majority of the secondary hemorrhages from the adenoids are from this periosteal area. So we purposely coagulate that. There is no musculature inside to give any complication. And see, this 5 minutes of irrigation will give you opportunity to watch for any bleeding. Can you see any? Hello?
Absolutely none. Absolutely none.
See, we have been irrigating for last couple of minutes and no irrigation, no bleeding, no even a single micro drop of the blood coming. Okay? So that's all about our adenoid. This comprehensive technique, what do we achieve with this technique? Last one. This comprehensive technique, what do we achieve with? Number one, complete removal of the adenoids. That is most important. Number two, under vision complete removal. Number three, uski CD dal lama. Number three, hello?
Yes, please.
Yeah, the number three is under vision, you protect all the critical structures under vision. There is no question of giving, damage to the surrounding muscle, periosteum, eustachian tube orifice, or any other areas, vascular injuries, soft palate, everything under vision. And hemostasis, since you have a coagulator, you achieve the hemostasis very, very effectively. That too, all the time irrigated with the saline, so the minimal collateral thermal damage is associated with that. And this is what are required in these children. So, any
So, Dr.
question, any
Satish,
comments, Dr.
yeah, there is it's a great technique, very safe, and I must say this. It's probably after so many years of done such a thorough adenoidectomy done. That's fantastic, and you can see how bloodless it can be if you are meticulous about your technique. So there is a question about you. It's a very different question.
Please.
Somebody asking, what is your typical working day like?
What is?
Because we can see you got so many cases planned up. You started early, and with just one case after the other. So how is your operating day? How is your typical working day?
My typical working day is interesting. We have a long theater, almost more than sometimes 12, 15, 18 hours every day.
Oh my goodness. Okay.
And we have a team. We have a teamwork. We are a team of ENT surgeons working together with me. Some of them are with me for more than 20 years, who are masters, and at our centers, we have done so far more than 200,000 surgeries, from minor to major till extensive skull base and even intracranial cases. And we have a team, some who are specialized in otology, who are specialized in rhinology, who are specialized in head and neck. And I am there with them for everything. So it's like we have all the time theater running. And at the same time, yes, the outpatient department as well. So we have variety of cases we cater every day, not limited to the rhinology or otology, head, neck, skull base, we practice all cochlear implant and other specialties of ENTs. So that's how.
So how do you plan your own personal operating? What is your case mix like on a typical day? Your own personal operating.
So you have to adjust, with time you get used to all these things. But yes, see, whatever you do, you have to work with passion. So it automatically happens.
Yeah, I can see all these complex rhinology and skull-based cases, and there's a high volume of it every day. So that's so great. Even we're almost spending a day with you today, and it's such a wonderful opportunity to see the whole range of it. And this was not really planned adenoidectomy, but again, it was wonderful to have watched something else. And the context was about CRS related adenoid implications of to the CRS. And also, I think if taking this question to the skull base, Dr. Satish, that if you were to do, say, orthodontite peg approach, how would you take this further? I mean, would you do in a similar fashion? There is always some, even in adults, sometimes there is adenoid tissue and all that. So would you take it this a similar fashion?
Yes.
Use the similar techniques.
Yes. See, when it comes to skull base, again, this is extension of endoscopic surgery. I told you, it burst with endoscopic sinus surgery in 70s with phenomenal work of Professor Messerklinger and Stamberger. And how, with the advancement in the surgical technique, instrumentation, better understanding of the anatomy, how the things are expanded. So every endoscopic surgeon, it requires a teamwork. It requires a lot of backup, can go ahead and work the skull base as well. There is no limit. What we call the skull base surgery nowadays is boundaries unlimited. And any endoscopic surgeon can do it. It requires definitely training in terms of, getting used to instrumentation, in terms of getting used to anatomy, a lot of cadaveric dissections to getting used to anatomy and instrumentation. And of course, your imaging, tools, backup, all these things are required for the science of skull base. It's not difficult. Yes, it is challenging. There is a lot of morbidity and sometimes even the mortality is also involved. It requires a lot of counseling as well to the patients. But yes, skull base is something which is coming up like anything, endoscopic or microscopic. We believe in 360 skull base, not the endoscopic skull base only. Skull base is one entity, 360. And there are various areas to approach the skull base through. A lot of people approaching the same lesion through the lateral skull base, same lesions through the endoscopic skull base, same by transfacial approaches, same by intracranial approaches. So what we believe, one has to be 360-degree in addressing the lesions by optimum way. It doesn't mean that if you know endoscopic, every patient you are treating endoscopic, which is not justified. So you have to, weigh the pros and cons and accordingly approach certain lesions. Like, for example, many a times the petroclival lesion, we approach endoscopic depending upon the favorable anatomy and the other hearing and other status. Sometimes we approach through lateral skull base with some favorable indications and anatomy. Sometimes with the transcranial approach because there are concerns over it when the vessels are involved and other things. So, see, this science is unlimited and you have to learn every day to go ahead.
Oh, thank you. That's so welcome message. I think the next case I gather is sinus surgery, correct? It's a primary sinus surgery.
Yes, primary sinus surgery. So lastly, for the adenoid, this technique is designed to do a comprehensive adenoidectomy with no question of recurrence or so anything, along with followed by medical treatment. And more importantly, preserving all structures all around. If you damage with the cobblator, removing the adenoid for the sake of preventing bleeding, fear of bleeding. If you are removing the adenoid with the cobblator, you end up tearing the, muscle and the perimysium and ultimately the nasopharyngeal cicatrization, infection, stenosis, all those things are very, very frustrating to treat. So we believe in finding this plane with little bit of the bleeding with the cobblator so as to protect the plane and then use the cobblator judiciously for whatever minimal bleeding happening. So this serves the purpose of preservation of all surrounding structures at the cost of minimal bleeding. That's the message for this technique. Thank you.
Thank you. Thank you so much.
Going on to the next case, are you getting any scan?
Yes, got the scans.
Yeah, so this particular patient has a typical history of unilateral headache. No allergy, no other symptoms, solely headache, for which he had consulted neurologists a couple of times and ultimately somebody did a scan of the sinuses, and this is the picture I'm going to share with you. So again, once you do the scan, the important thing is to have fine sections, some millimetric sections in the dicom format. The beauty of the CT scan is you don't need to scan in every plane. Just scan in axial format and use this software to reconstruct in all planes. Unlike MRI, which has to be shot in all planes separately. So here, these are some millimetric scans, and what you see on axial is opacification of the left side frontal sinus. Can you see?
Yes. Yeah.
And then minimal ethmoidal disease. Now, let me show better in the coronal plane to understand it better. Now, see, this particular patient has a unilateral gross frontal sinusitis. You can see the frontal sinus drainage pathway is affected. That's why leading to this problem. Now, see this, the floor of the frontal sinus formed by the beak. See, if I come from anteriorly, the frontal bone, frontal sinuses, intersinus septum, this is incomplete. This is what convolutions. See this? And now this is the floor formed by the beak. Beak. Now from behind, as you go behind, where the beak ends, the frontal sinus drainage pathway starts. Can you see?
Yes.
And this is because of the fault in the drainage pathway here. It has led to this kind of sinusitis. This patient has a minimal ethmoidal sinusitis Even the turbinate sinus is there. See, this turbinate is affected. There is a air cavity in the turbinate which is opacified. You see there? So this is the osteomeatal complex. This is also compromised. But as you go behind, everything is clear. When you go behind, there is no disease. See this. This is your, let me show you, first coming anteriorly. This is the middle turbinate going up to the skull base. When you go behind, now this is the middle turbinate turning to go laterally onto the lamina. This is basal lamella. Further going behind, see now these are the posterior ethmoidal sinuses, pretty clear. This is the superior turbinate and then the front sphenoid sinus. Those are pretty clear. So the mucociliary clearance from the posterior group of sinuses is pretty clear. This is a limited disease affecting the anterior group of sinuses on the left side. Can you see? And this is solely because of obstruction to the drainage and ventilation. And these are the best cases to treat for immediate outcome. There you don't need to follow with a lifelong treatment. These are not eosinophilic disease patients wherein a lifelong, further treatment with a douching and other allergy and other comorbidities are to be treated for life to prevent recurrence. So here, the anatomical abnormality number 1. See this, the drainage pathway of the frontal sinus. If I put up in 3D format, let me show you first on the sagittal plane. See what is there. This is your beak. Can you see the beak?
Yes, very thick, isn't it?
This beak forms the floor of the frontal sinus. Can you see?
Yes.
And this beak narrows the outflow of the frontal sinus. See this? In our technique, beak is the biggest landmark, most reliable landmark to get into the frontal sinus. It is always present. It is very safe landmark. There is no critical structure around that. See, the beak is so anterior a structure. No skull base along with it. Can you see? Endoscopically, we use 70 degree, find the beak, follow the beak, where the beak ends in the frontal sinus. See very clear. Where the beak ends in the frontal sinus. Now, this frontal sinus aeration is blocked by compromised with several structures. See, this is the frontobular cell going up. Can you see? This is the frontobular cell going up. This is the frontobular cell going up and compromise the drainage of the frontal sinus, narrowed the outflow from behind. Similarly, this is the cell. This is the agar cell which is attached anteriorly. Can you see this?
Yes.
It has narrowed the frontal sinus outflow from front. This cell is, let me show you in a bigger perspective. This cell is narrowing the frontal sinus outflow from behind, and this cell is narrowing the frontal sinus outflow from front, and overall the frontal sinus outflow is compromised. Can you see? So in order to establish the ventilation and drainage, we'll go endoscopic, we'll find the beak, we'll clear all these cells compromising the drainage pathway from anteriorly and posteriorly. This is a basic case for sinus surgery, exclusive frontoethmoidal sinusitis, only anterior sinusitis, and that too because of the anatomical predisposition of the structures blocking the drainage pathway. So these are the cases which have favorable outcome. This is not eosinophilic, frustrating eosinophilic disease which requires lifelong steroid and other treatment. So purposely I kept the first case, the simplest one to treat. We'll go on the left side, we'll do anterior ethmoidectomy, we'll go up, find the beak, and you will find the frontal sinus behind, and we'll widen the drainage pathway to the limits. Anterior limit is beak, posterior limit is skull base, medial limit is turbinate, and the lateral limit is lamina papyracea, and will remove everything, all septations in between, to give parallel, pathway for the frontal sinus drainage, the outflow and the ventilation. So this is going to be the course of action in this particular patient. Limited disease.
So, Dr. Satish, what is your plan for the other sinuses? Say, for example, on the other side, although it is normal,
Other side is pretty
and the
clear.
posterior ethmoid, the sphenoids on this
Yes.
particular side. So,
In
what
this-
will be with it?
See, this sinusitis is because of this anatomical predisposition of the structures at the level of frontal sinus outflow. This is
Okay.
not because of any other systemic cause. That's why it is not affecting the outflow and drainage of the other sinuses. On the
Yes.
opposite side and the posterior group of sinuses on this side. So there is no need to treat other sinus. That's why I purposely kept this case.
Yeah.
This is the most
We had a very
rewarding.
interesting discussion with Professor Richard Harvey this morning. I mean, but a very similar case, isn't it? Just prior to this session, as again very similar unilateral disease. We had the discussion about what to do with the normal sinuses.
Yeah.
And like you, we had really held the same view that if address only the sinuses which are affected, and there's no really, because there is a tendency to think, oh, okay, while I'm there, I might as well address, at least do the minimal sinus surgery, do the middle metal antrostomy. You can see a larger concha on the right side on the scan compared to the left one.
But which
So
is not
the concha
bothering.
excision, but yes, exactly. So is it really necessary? That's the
Not really. The next case
Yeah.
we are taking is a eosinophilic situation with generalized involvement of the sinus mucosa. This is different situation. This is non-polypoidal, non-eosinophilic, kind of sinusitis, wherein the anatomical predisposition has given rise to this kind of situation. And we will treat that anatomical predisposition and widen the frontal sinus drainage pathway to treat this condition, adequately. So this will not require any long-term treatment. Every sinusitis is different.
yes.
There are variety of endotypes for eosinophilic sinusitis or type 2 kind of disease, allergic disease. There are variety of endotypes, allergic frontal sinusitis, allergic fungal sinusitis, AERD, eosinophilic sinusitis. There are variety of situations, predisposed, and every endotype has a different underlying pathophysiological pathway or predisposition which needs treatment further. Here, it is the simplest, straightforward situation. You open up the sinus ventilation and drainage and get away from problems. So the case is ready. We'll go ahead with this. The next case is a eosinophilic sinusitis. We'll discuss. And after that is a revision situation. So in order, one by one, we'll go by all the three cases. Okay?
Yeah, great. So for the junior slates, it's a very consistent message from both of them, from Professor Richard Harvey and from Dr. Jain as well, that it's not a blanket
Absolutely.
sinus surgery. You
Yeah.
have to take into consideration disease factors and the extent of the disease and tailor your surgery to that. You cannot go
Absolutely.
with the mindset, okay, I'm going to do now everything possible because
Yes.
I can do it, or I want to do it, or it can be done. So
Dr.
what
Okade.
is required?
Especially lack of disease on imaging and also lack of symptoms on that side. I think the message is don't operate just because you can.
Yeah, exactly.
Yes.
Yes, Dr. Satish.
Dr. Okade, I am one of the biggest friends of Richard Harvey.
Yes.
And there is a lot to learn from him, who has done extensive work about the pathophysiology of understanding the pathophysiology of this disease
Yeah.
at the molecular level. His publication, his research work is something phenomenal. And I've gone through his book as well. This is amazing. We must know the pathophysiology of this disease. This is not mechanical disease to treat. You know what happened? When this science burst in 70s with Messerschmitt's work, the Stamberger was so popular everywhere in the world doing sinus surgery, propagating, and everyone started sinus surgery. What happened after a couple of years, in spite of having done best sinus surgery, wide opening of the sinuses, a good, well-done sinus surgery establishing ventilation and drainage, yet polyps coming out. And that led the researchers to work into understanding this disease, that what kind of disease it is. So this sinusitis is a complex disease. It has been very well recognized that this is an immune complex disease driven by certain inflammatory cytokines. And immunity is the main, sinonasal immunity is the main which is breached to cause this sinusitis. So anything which improves the immunity improves the overall outcome. Anything which affects the immunity negatively is a negative outcome. And this understanding of this disease at the molecular level is the key for every sinus surgeon to give best outcome. And this is what I learned many a times from Richard Harvey, who is not only a great teacher, but a great surgeon as well, and a great researcher as well. And with your workshops, we have always learned from many of such masters. And thank you so much once again, Dr. Rukade, for this opportunity. So now we are going ahead with the case. You can continue discussion, questions, anything during surgery.
Yeah,
Okay?
sure. Thank you. In a similar journey, Prof. Harvey shared this morning that when he started the sinus surgery, how the principles were about making a drainage passage, providing ventilation, and with the hope that the disease process will recover itself. From that point on, to now the concept is maximizing the cavities and for providing the access to medical management. So there is a changes in philosophy, or not only the techniques but approaches.
And I think that's why a lot of surgery fails, isn't it? Because it's just axillary clearance is not adequate. So I think what we saw today, making sure that in maxillary sinus you don't have a sump, but also the same in the sphenoid sinus, where you bring the face of the sphenoid right down so that it's level with the floor of the sphenoid sinus, just so you get that gravitational drainage as well.
Again, after seeing the front approach to the frontal sinus yesterday, it will be interesting to see how Dr. Satish approaches the frontal sinus. It has a different technique. Saw that some surgeons have the preference over the straight 0-degree endoscope. And Dr. Satish mentioned that he'll be using the angled endoscope. The beak is the landmark that he relies on. He finds it more consistent and very, very helpful. So again, having witnessed different techniques, different approaches is really enriching. And then there are instances when one approach doesn't work. You need different approaches.
That's yes. That's what I was just about to say, Ashok. So I think it is important if you're doing frontal sinus surgery that you feel comfortable with a number of approaches, because one size doesn't fit all. So an outside-in approach is good when you've got that very small AP diameter, but there are other situations where you need to be able to use an inside-out approach, or you may even need to combine the endoscopic with an open approach. And I do think if you're operating in the sinuses, you should be able to choose the best approach for the patient and for the pathology.
Correct. And again, the revision surgery, it has its own challenges. And not only the revision of sinus surgery, but the revision of frontal sinus surgery. And the landmarks, sometimes the absence of the landmarks. And that is where all these approaches can be helpful. Would you consider balloon sinuplasty in a case like this, Louise?
I wouldn't in a case like this, because I think the anatomical abnormality that's causing the issue is that bone that's coming from the orbital wall, the medial orbital wall, sort of roof of the orbit. And I think you would struggle to deal with that with balloon sinuplasty.
Yeah, some surgeons might take a view that balloon sinuplasty may be an option here.
Yeah.
Yeah, isolated frontal sinus disease. There are
Absolutely.
narrowing of the pathways. It'll be interesting to see what Dr. Satish thinks about it.
Hello.
Hello, Dr. Satish. We're back. So we're just discussing whether, do you see balloon sinuplasty has any role in this situation? What is your view on that? Balloon sinuplasty.
Balloon sinuplasty is, to me, has no role at all, number one. Number two, it's not about deflating ostium. You have to treat the underlying, abnormal anatomy, abnormal cells to prevent the recurrence. So, balloon sinuplasty is a very poor way to treat for definite treatment, I would say. In this patient, see, I'm using Merocel here for the decongestion. Can you see something, the high deviation?
Yes. Yeah.
High septal deviation. See this? This high septal deviation has made this turbinate paradoxical. Can you see this?
Yes.
Yes.
See, a single problem of high septal deviation can give various problems.
So, Louis, they're very unambiguous opinion on place of balloon sinuplasty in this case. So, it is clearly not going to work in his opinion.
See this high septal deviation can contribute to so many issues many a times. See this?
So what is your plan now? So are we planning to deal with the septal deviation or work around it?
Yes. So what we believe, see, many a times find that you can go ahead after decongestion without treating the such septal deviation. But what we believe, this septal, high septal deviation should be treated. You know what happens? Otherwise, working through the narrow spaces can give royarias, can invite synechias, and can ultimately obstruct the ventilation and drainage, and future irrigation also. So, see this has pushed the turbinate and made it, paradoxical. And this high septal deviation is treatable problem, and like couple of minutes it takes to treat this problem forever. So here I will show you first treating this high septal deviation.
Absolutely agree with you. I'm very low threshold for considering the septal correction because ultimately somewhere or the other. Yeah.
I am not doing anything much. I'm just doing limited septal correction.
But yeah, I mean, you're doing it for access, and if you try and cut the corners, that might compromise your surgical outcomes, as Dr. Satish has mentioned. And you confront this situation often with we are doing an endoscopic DCR surgery. So for a procedure like that, almost 40-45% of the patients, they require this correction to have a good access to that area.
Yes.
And we'll be operating in a similar area.
I think as well, it doesn't take an awful long time to do that. And if you don't do it, you end up regretting it as you go through the procedure. And then, as you say, perhaps in the post-operative period, the outcome's not as good.
Yeah. Again, to notice the time well spent in getting all that decongestant working. So very meticulously in a gradual advancing fashion.
Hello.
He's using the decongestant.
Hello.
Hello, Dr. Satish.
See, our area of interest is to treat this high deviation, not to treat any entire septum. So what I'm doing is making an incision much behind. See this? And not very big one. बंद है यार उसको काम क्या कर ढंग से See, I'm elevating this flap on this side. See, in the right plane, can you see?
Yes. Yeah.
Yes.
And I'm going to remove this limited deviation only. See this?
Yes.
Going to the opposite side.
For the sake of juniors, it is so important to get into the right plane. And you notice that how Dr. Satish got into the plane effortlessly. But ensure before you advance that you're in the right plane. So that way you're avoiding any mucosal tears.
I think when you do this with the endoscope, we were saying that earlier, I show.
See, I am removing only the limited deviated portion. Only the limited deviated portion. See this? Only limited deviated portion. Let's see. See how this turbinate has been pushed laterally. See how much the septum was pushing the turbinate. See this?
Yes.
And this has made this turbinate paradoxically bent. So now I will give some microfracture to this turbinate. Though this turbinate has a concha also according to the CT scan.
This is to exercise the concha? Or,
yes. See, I am just giving the microfracture to open up the middle meatus adequately. See, I am not at the entire septum. Only this area which was giving high deviation. Could you see?
Yes.
If Very well clear. Can you see? No more
Yes,
high
very
deviation.
clear.
Now you can see no more high deviation. See now the middle meatus. See, previously it was, and now it is. Can you see?
Yes, very clear.
Adequate space in the middle meatus. Can you see very clear?
Yes, it's very clear.
Secondly, this component is involved with a disease which treated also later. Now, the first part of the surgery is this is the uncinate process. See this. This is the vertical portion of the uncinate. This is the horizontal portion. So I am biting through the uncinate, turning it little below to open up this infundibulum. Then and fracturing the lower uncinate to open up the middle meatus. See this? That's the maxillary sinus. That's the lower part of the uncinate, which I am removing with the shaver. This is what I have done is the middle meatal antrostomy through biting. Okay, this is middle meatal antrostomy. In this particular patient, the middle meatus was compromised, so we are doing the main issue is the frontal sinus. This is the through biting. To remove this part of the this is adequate middle meatus opening for this, the maxillary sinus opening for this, as the maxillary sinus doesn't have any significant disease. You don't have to go for mega middle meatal antrostomy. Okay. God's word, another sense. So now this is middle meatal antrostomy, simple. I'm done. This is middle meatal antrostomy. Okay. Now our goal of area is frontal sinus. So we have to go. How is the picture there, sir?
It's very good. It's good quality.
Okay. Now for the
Okay for your legs?
upper part of the uncinate, I am just going behind the uncinate and fracturing it anteriorly. See this? going behind and fracturing it anteriorly. This upper part removal is a very important part, as it takes you to the lateral limit of your sinus dissection immediately, as it is closest to the lamina papyracea. When we remove the upper part, we should be able to see the lamina papyracea in the beginning. See, that is the lamina papyracea here. Can you see?
Yes.
Yes.
That is your lateral limit of dissection. Now I am opening up the axilla thoroughly and then go with the 70 degrees. And see, there is disease. Opening up the axilla thoroughly. Yes. Now, at this stage, see, we have maxillary sinus, we have the bulla. I have not disturbed the bulla yet. Not remove the bulla yet. Bulla is a very.
So is that the intact bulla technique that you're planning?
This bulla, most of the time it goes towards the skull base. Most of the time. And most of the time, when it goes towards the skull base, anterior thyroidal artery runs behind that. See this with the marrow cell again, and we go with the 70 degree. The only thing which is important here, further frontal sinus work with the beak. I told you during CT scan as well. This is with the 70 degree now. See, this is bulla, and I am going up. See there?
Yes.
This is your beak. This is your lateral limit lamina. See all the lateral limit lamina. This is the cell, Agarneji, I told you, which was coming and narrowing the frontal sinus drainage pathway from anteriorly. This is the cell. See this cell?
Yes.
If I remove it anteriorly, it will open up the frontal sinus drainage pathway. What you need to keep in mind is your medial limit, that is turbinate. Your medial limit is turbinate. Now see with 70. I am able to see my medial limit. I am able to see my lateral limit. My lateral limit is here. If you keep this lateral limit in view, you cannot damage orbital contents. This medial limit is your turbinate. If you follow the turbinate as your medial limit, simply you cannot damage anything. Now see what I am opening. This is my beak. See this beak? This thick bone is the beak. Follow the beak, follow the beak, follow the beak. Where the beak ends, this is frontal sinus. That is the frontal sinus. So, see how it is compromised by all around. And we have to treat that. There. See this? Let me put it back for a while to show you better. I hope you are oriented with 70 degree.
Yes, we are.
Yes.
It's quite a good view.
See, this beak is the
It's very
biggest
good.
landmark. As long as you follow the beak, where the beak ends, the frontal sinus. This is most skull base is behind. So when you work at the level, no skull base comes, nothing, no fear of damaging anything. the beak and the frontal area. Can you see the cells clearly?
Yes.
That's the agar which is sitting on the mouth of the frontal sinus. That's the beak. And here is the frontal sinus drainage pathway. So this is coming from front. See this? I'm
Yeah, that's the
taking
posterior
cell
cell.
from the front. I'm taking away this cell from the front.
Yeah.
And that is the frontal sinus outflow I'm getting into. See, my beak is in view. All the time, keep the beak in view. Hello?
Yes.
Yeah. Keep the beak in view. This is beak. And I'm going up behind the beak. This is my true frontal sinus. See this?
Yes. Now you can see the mucus coming out.
Completely blocked. See the purulent secretions
Yes.
Yes. Yeah.
giving this patient symptomatology. See this? Now, this beak is the challenge. See, this will relieve him. See this? So now
Yes.
articulated. Now, widen this area by punching out this portion of the beak. Widen this for you. See, I'm using the articulated punch, a very special tool to punch out this beak. See this? This will open up the space much better. This is articulated punch. This will punch out this beak. See like this?
Can you show us the whole instrument, please?
Pardon? This is a special tool from Karl Storz. Articulated punch. See the beak overhang was so much, which has been reduced with the articulated punch. See this beak? I can further little bit reduce. This articulated punch. See this? See the frontal sinus from where the pus is coming out. Right, 120. Could you locate the frontal behind the beak? Hello?
Yes, yes, we can see the frontal.
This is my beak. See, this is my beak. And just behind that, this is all frontal sinus. See this?
Quite a bit of mucus there, wasn't it? Yes.
Yes.
It's quite
Yes.
full.
So I see this is not a complete work. You have to do an adequate work. I will show you to prevent this problem for future. Articulated punch. There are cells from either side which are narrowing this. Next is under करा दूं. See, I am further removing the part of. See this? See this widening?
Yes.
Yes.
Wash the under. Now I will give it a wash inside the frontal to flush out. See inside. What up? To flush out all these purulent secretions. Now, Jacuret. ये नहीं है जो यार ओरिजिनल जैकेट लेके आओ See, this cell is narrowing from lateral side, this cell, which I am breaking. See, I will flush it till lamina paprasia. You have to give the adequate for the ventilation and drainage. The See, this thick septation had compromised the frontal sinus drainage pathway from laterally. Would you see?
Yes.
Yeah. Now this posterior compromise reverse. I'll be using the so-called adenoid blade now. I told you last time, condemn using for the adenoid because it is rear facing blade. But here at the skull base, it becomes front facing with a 70 degrees. See this? This blade becomes front facing. See now the cutting edges?
Yes.
And I'm widening by removing the septa from behind. See, this is adenoid blade. From widening this posterior cell, see, this is the posterior table of the frontal sinus.
So, Dr. Satish, while
Can you
you're
see this?
operating,
Yes.
we had a bit of a change of guard here. So we have our very good friend from Perugia, Italy, Dr. Puya Degani Mobaraki. He's an radiologist there. He's joining us on a hosting panel. So welcome, Puya.
Good morning, everyone. Thank you, Ashok. Good morning,
Satish.
Good morning.
So Louise will be leaving for her clinical duties. So thank you, Louise. Thanks for your wonderful hosting. Hope you enjoyed it.
Okay. Thank you very much. Yes. And thank you, Dr. Satish. That was excellent. Thank you.
Goodbye, Louise.
See now the widening of the frontal sinus. The huge widening because the cells on either side, the posterior cell, the front of compromising from here, and the big organage was compromising from front, which ultimately narrowed the frontal sinus drainage pathway. Now, how we went about? We went to the level of the beak. See my beak. The beak was overhanging, so we nibbed a part of the beak, nibbled the part of the beak, and removed the cells from either side to widen the frontal sinus drainage. Now this is part of the upper attachment of the bulla I am taking off, and see the skull base behind. This is anterior twaddle skull base. As long as bulla is there, there is no question of anterior twaddle artery coming in your way, which remains behind reverse. See now the frontal sinus and the anterior twaddle roof. I'll do further work at the anterior twaddle roof to widen it. And the portion of the bulla to complete the surgery. See this? Again the reverse blade for the skull base. See, it makes my cutting edges visible. Under one can work with the skull base. This is the adenoid blade. With 70 degree, it becomes front facing. See this? Now I remove the upper portion of the bulla. You can see the anterior twaddle artery behind. Can you see the artery behind?
Yes. Yes.
Yes.
So as long as the upper part of the bulla going to the skull base is intact, the artery remains protected. Wash. See the secretions coming out of the frontal sinus. You have to wash. You have now this was the reason of symptoms to this patient. And this was pure non-polypoidal sinusitis, no generalized disease. These anatomical, abnormalities predisposing to compromisation or compromising the ventilation and drainage of the sinus, which led to. See, the mucosa is going to settle down once this ventilation drainage is established. You don't have to be aggressive at the mucosa every time, you know. So now my what work for this particular patient from here. See, this is the part of the bulla which I will tackle with a 0-degree layer down. See this. This is the frontal sinus work done for this patient. I hope it is very clear.
Yes. Very much so. Yes. It's wonderful.
See
Once
how
you're done,
big-
if you just show all the landmarks before we.
I have widened the frontal sinus to the limits. The lateral limit is lamina, medial limit is turbinate, anterior limit is beak, and the posterior limit is skull base. See this? The frontal
Yes,
sinus,
yeah,
which
yeah.
drainage path is clear. Now I'll change to 0-degree and remove the floor of the bulla and complete this anterior ethmoidectomy. See behind that, ground lamella going to the skull base. See, this is ground lamella. This first part of the turbinate turning to the second part, which is ground lamella. Bulla, which I am taking off. See, this is bulla. Behind that is all ground lamella. So this completes my anterior ethmoidectomy, and in this particular patient, only the anterior group of sinuses were affected. So I'm doing this
Satish, would you please showing us before proceeding to the ethmoid, the anterior ethmoidal artery?
Yes,
Thank you.
yes, I will. That's a great point. I will. See, anterior ethmoidal artery is always a concern or something which frightens the endoscopic sinus surgeons. See, a lot of things into consideration to protect the anterior ethmoidal artery and stay away from it. Number one, this artery leaves the orbit. This leaves the orbit. See, the artery is there. It leaves the orbit from the posterior most part of the anterior ethmoidal roof. What I mean to say, see the frontal sinus anteriorly. I am with 0-degree now.
Yes.
The beak is here. Beak is here. Beak is here, and this is, look now. This is frontal sinus, and this is the beginning of the anterior ethmoidal roof behind that. So from here, the anterior ethmoidal roof, anterior ethmoidal roof, anterior ethmoidal roof going behind, and at the posterior most part of the anterior ethmoidal roof is this vessel which, leaves the orbit, run in the roof of the ethmoid to enter the lateral lamella of the turbinate to perforate that and then enter the olfactory fossa of the brain. So this runs through the posterior most part of the anterior ethmoidal roof. Now, with 70-degree, we were working at the level of the beak. See the beak level there. Imagine. Bolo na yaar.
I think we lost audio.
We lost the audio from
Yes.
Jaipur.
अचानक क्या हो जाता है इसको यार? कुछ हरस हो जाता हूँ बैठा बैठा, उसको पता ही नहीं जा भी रहा है कि नहीं.
Dr. Satish, can you hear us in the theater? We can't hear you.
अरे यार,
Sorry, Dr. Satish, can you hear us? We can't hear you. I think we seem to have lost the sound.
नहीं आया ना यार.
So, Ashok, I think that even in this case, if we think about what we were actually discussing yesterday, the importance of having angled instruments to reach to difficult point, allow us to places that were impossible to reach endoscopically years before, even 10, 15 years ago. And the importance of using those instruments is mandatory to perform a safe surgery. Even without the use of navigation, we can reach to these places by using appropriately. So what is your thought and your suggestion for the younger generation when performing extensive frontal surgery? Would you agree to the development of a flowchart scale before proceeding further?
Yeah, absolutely. I mean, formally or informally, you need to have your strategies in place, and you should have formulated your surgical plan. So it starts right from the beginning with the assessment. And before you joined in, Dr. Satish so very elaborately discussed the importance of the scan, studying the scan, knowing your anatomy. So there's no replacement for knowledge of anatomy, and also then that specific anatomy for that particular patient, the disease, the extent of the disease. So once we have studied in detail, you need to have your own plan in mind. And navigation really has a role to confirm that you already know. It's a very integral.
Oh, wow.
It's also, there are some medical legal aspects to it. When it is recommended by your national organization in certain situations, not using it, then it exposes you to some challenges. And again, depends on the level of training, expertise of the surgeon, seniority of the surgeon. So I would suggest to the trainees who are watching it is rather err on the side of caution, that at the beginning, it is good to have that than not having it if it is available. And of course, the learning stepwise instruments, definitely we discussed yesterday that you should have all the necessary range of instruments, equipment that you require, including these angle scopes, angle instruments. And it's a beautiful punch that he was using for the frontal beak we just saw. I mean, that gives such a crisp bite and very quick widening of that frontal beak. Otherwise, you end up using the drill in that area. And as you know, once you put the drill in, there is a tendency for narrowing that ostium. So we clearly saw two views. today we're witnessing the angle endoscope approach, and we saw the benefit of it and how beautifully it could be done with all the adequate appropriate angles and the instruments. And yesterday we saw the very wide approach with a 0-degree endoscope, Caroline's window technique, the signature technique that Prof. Harvey describes. So both the approaches have a place, and it's really where you are trained, what you used to. But yes, you should have all the equipment, technology that is required for that surgery, otherwise you shouldn't be undertaking it. What do you think?
I think that referring to Professor Harvey yesterday, the technique of the axillary flap will allow us to reach frontal sinus directly with a zero scope. But it doesn't mean that we cannot use angle instrument to have a better visualization. And I think the most challenging for an endoscopic surgeon when it performed by it's exactly having a good field, visual field. So they came back.
Yeah, very right. And if you think what they were actually doing, it's not about the angle or this 0-degree endoscope. They're collecting and defining their landmarks.
Yes.
You saw Satish at the moment. He, at the very outset, he was, the minute he did the angiography, he was looking for his lamina. So that's his lateral landmark sorted out. Then the terminate, the medial landmark. And again, the posterior landmark was the intact bulla technique. Brilliant. Then you're not really worried about the damage to anterior artery, the intact bulla techniques. All these landmarks are sorted out. Then it's your anterior landmark, which he really firmly believes in, relies on, finds it very consistent, trustworthy. The frontal beak. So it's really, after that, seeking the beak and widening, working through the beak. And then once you establish the pathway, then breaking into the bulla and addressing the rest of it. So that was his technique. So similarly, Richard was doing this very similar. He was establishing his own landmark, like the first olfactory neuron, then the periosteum to decide the lateral extent, the nasolacrimal duct, again as a landmark, and then frontal beak. He also looked for the frontal beak. But once we drill all that, you had almost end-on access to the frontal beak area. And then from that point on, we descended down onto the frontal recess. So it's almost with the microdebrider, you could remove all those cell partitions. So that was another variation of the technique. And as we have seen, both have worked very well and given a very good wide access to the frontal and allowed us to deal with the pathology. Very similar unilateral presentation.
Regarding the nasolacrimal duct and the approach to the frontal sinus, it's fascinating how much in common at the end different schools of thinking and teaching are basically approaching to the same spot. Bernard Spreckelsen, to reaching the frontal sinus, was actually talking about the nasolacrimal duct as a pathway to go through that. Satish and also the Paolo Castelnuovo, Paulino Battaglia, and Turi, then also PJ. So everyone is actually defining the landmarks laterally, safely goes out and goes up to the frontal. So anatomy mandatory, and this is why I think that dissection courses are made up to practicing before going to the theater. This is the suggestion I always give to younger, and the importance of having the facilities that such courses as these 3 days are providing. It's basically giving you the aspect of the field in a live spot. Combining it together will give you the best outcome for the patient. So,
yeah, Charlie, and it's really great learning to see how these expert surgeons deal with the different challenges in real-time settings. So they're not unedited videos So it's a real-time setting, and you can deal with these are the situations you're going to come across, and you have to find your way around them. So it's really a great learning. These 3 days have given a very extensive exposure to different cases and different approaches.
There are a lot of people asking me, are those recorded sessions? Would you please where they can find again those videos, the recording section?
Yes, absolutely. It is recording sessions. I know people are joining from different time zones. They're not the most convenient times. Say, for example, we started here at 3 a.m. in the UK. So not many will be able to log in. So we will be having all this recording available, and it will be on our website. So if you become a GRN member, and we also have a YouTube channel, as you very well know, Puya.
Yes.
On the YouTube channel, all these videos will be case-by-case basis will be available. We already have the videos from our previous events there,
yep.
Live surgeries, and also of our other events, and they're regularly being accessed, and I get regular messages that people find it quite useful. So it is becoming a very useful reference source. So definitely after the event, these videos will be available. So you can become a member of a GRN Academy. It is free, and that's the way you stay updated. You can also subscribe to our YouTube channel, so every addition of the video you will be notified about. So it's a website, as you know, it's a www.globalradiology.com.
क्या आदमी है वो?
So what will be your message to our juniors who are starting with the frontal sinus surgery?
I always recommend to have a training step-by-step flow chart, which means a recording session of your surgery, analyzing it, and move forward. Because if you're not watching your step, you will commit same exact mistakes and will get not you further. So frontal sinus to me quite challenging. It was one of the first step when I've learned how to deal with the complication. And one thing that I would like always to suggest to the younger generation is to understand that before moving forward, you need to manage complication. You cannot deal with extensive pathology, even, for example, the cases that has been performed by Bernard Sprakelsen, the extensive Sumter triad or whatever it is, where you have a complete opacification of the sinuses, where you don't have landmarks. You might encounter, any kind of difficulties which lead to, for example, CSF leak. Are you aware of the fact that you need to repair the defect during surgery? If you say yes, then you can perform such surgery. Otherwise, always prioritize the patient's health. So dealing with complication is important. Managing those patients are important. Understanding the limits of your capacity is important. So two things should be important before proceeding to surgery is how to get to the frontal sinus, which need a lot of practice. The importance of dealing with CSF, the importance of dealing with epistaxis, which means damage to the ethmoidal arteries, which means what instruments should be used. Avoiding instruments, for example, monopolar cautery, for epistaxis due to damage of the anterior motor artery, the importance of avoiding such instruments, the importance of the lacrimal pathways when you're performing, for example, advanced maxillary sinus surgery. If you want to perform pre-lacrimal approaches, if you want to perform modify Denker or Sturman-Canfield approaches, the importance of knowing the landmarks when performing sphenoid surgery and how to preserve, for example, olfaction, how to tailor your surgery when performing flap reconstruction for defects such as perforation. All this goes to a point in which anatomy dissection courses will allow you to understand such anatomy. Live surgery events will get you to a point in which you combine different teaching, school of teaching, to understand how to combine them to get the best results. So juniors must attend dissection course, like everything that gets them to a point to avoid mistakes and injuries.
So thank you, Priya. That was great. So I think we'll take a very short break, play some information videos during the break. Medtronic and Karl Strauss, they have supported this event. Event of this magnitude is not possible without their support. So they have sent some information videos for us. So we'll watch it. And after that, we're joining Dr. Satish Jain again for another interesting case of extensive sinus surgery, and then followed by CSF leak. Thank you.
Thank you.
Definitely navigation is needed in certain circumstances. As I was saying before, Diffusion case, or if it's a tumor that has destroyed key anatomic landmarks.
Hello? 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 Yeah, straight. So there was some interruption. I'm very sorry for that. I don't know what happened. But now I hope you are getting the picture. So just to show you the final picture of this particular patella. This was the middle meatal antrostomy, the lamina papricia with 0 degree, and you see the frontal sinus up. We had shown you frontal sinus up here with a 70 degree. The frontal sinus work was done following the beak with the 70 degree. And see, this is the anterior artery. This is your ground lamella going up to the skull base behind. That was the bulla removed. Posterior group of sinuses are normal, so we didn't bother to do anything to it. Now, lastly, this was the septal correction we did, the partial septal. Lastly, this turbinate we saw had cell. Scissors. At the end of the surgery, as we have used the turbinate as a, our landmark for the sinus work, this part of the turbinate has a lamina, has a cell. So I am doing a partial turbinate resection in this particular patient purposely, because this is a cell. See this? The lumen of the turbinate, there is a cell, and this is not going to give any harm for the regions that it is. I am not leaving any raw areas, and this is going to improve our visualization also for the future. This has taken away the turbinate cell as well, and this will allow our future follow-up maintenance in case the topical therapy required. everything will improve with this limited partial turbinate correction. So this is all about this particular case, as we are not going to, address the posterior group of cells. Any
Satish,
questions here? Yes, please.
Satish, please. Would
Yes,
you
please.
use a ball probe and show the direction of the anterior ethmoidal artery?
Yes, yes, yes. Why not? See this. The anterior ethmoidal artery leaves the orbit here. And it then runs obliquely, anteriorly to enter the lateral lamella of the cribriform plate. See this artery runs obliquely anteriorly here. Here is the level of the lateral lamella of the turbinate, which has to be dealt with very, very caution, as this is a very thin bone, and even the smallest trauma to this bone can lead to a CSF leak.
Perfect. In your practice, have you noticed somehow a different angulation of the anterior ethmoidal artery, which usually comes from posterior to anterior, to find out other relationship or angle?
So anterior ethmoidal artery variations are quite common, and it all depends upon the, pneumatization of the anterior ethmoidal skull base. When the anterior ethmoidal skull base is too pneumatized, this artery often is, sometimes it runs through the mesentery, sometimes it runs much below the level of the skull base, sometimes it is over prominent, and sometimes because of the huge supraorbital cell, it can be pushed even more further behind. So it all depends upon the anatomy of the anterior ethmoidal skull base, the cellularity of the anterior ethmoidal skull base, which actually dictates the course of the artery. So it depends. So every case is different, and your CT scan can warn you from such abnormalities if you go through the fine submillimetric CT scan, three-dimensional CT scans carefully. That can actually tell you how the artery is placed, how posterior it is, how the anterior ethmoidal skull base is pneumatized, whether it is running through the mesentery, how below it is, below the level of the skull base, how prominent it is. So entire course of the artery can be seen by means of a good CT scan.
Thank you.
So this was about a simple situation of a frontal sinusitis because of anatomical predisposition. This was not because of any generalized disease. The next case we are taking, any question regarding this case? Any more?
Looks brilliant. Perfect. Thank you.
Thank you. The next case is again a sinus surgery case. I told you this is a revision case. See, this has been a known case of allergic fungal rhinosinusitis, which was operated earlier. Allergic fungal rhinosinusitis is because of the person being allergic to fungal antigen. See, we are exposed to environmental fungus when we inhale. Fungus is ubiquitous in the air, and mostly who are not allergic to whatever fungal is inhaled is expelled by the mucociliary activity into the nasopharynx and gut normally. Those who are allergic to allergic phenomena, whenever the fungus is exposed starts and the eosinophilic action starts, and if this fungus is trapped into any of the sinuses, this phenomena of eosinophilic activity starts, and give a classical picture of allergic fungal rhinosinusitis. So this is a pure allergic disease. This is a different endotype of a polypoidal sinusitis. This is a type 2 allergic disease. It is an antigen-antibody reaction for which steroid is the treatment of choice. So the fungus acting as an antibody reaction for which steroid is the treatment, we have to plan a proper treatment for such patients. So such patient requires a full house sinus surgery to remove all fungal antigen. And at the same time, it gives you an opportunity to open up the wide opening of the sinuses so that you can douche the steroids later on. You can do steroid douching. You can push the topical steroid deep into the sinuses which actually is the mainstay of treatment. The fungus is the disease, but the treatment of choice is steroid because patient is allergic to fungus and eosinophilic activities come into place to give rise to this picture. So the post-operative treatment is all, aimed at introduction of the steroid to the sinuses. Initially oral, and to avoid oral, the topical steroids are more effective in the post-operative situation when you do a full house fest. When you open up the sinuses widely, it gives you better opportunity to push the topical steroid, yet without systemic side effects. So those patients require long-term topical steroid therapy, long-term surveillance, and then further the skin prick allergy testing, immunotherapy and other treatment to aim the treatment at the primary disease. Now this classical patient, see this is a known case of allergic fungal sinusitis, was operated earlier. Now look at the picture. A fairly good sinus surgery has been done, but when we evaluated the patient with the history, no irrigation was done. No post-operative long-term irrigation was done, and what you can see, the same picture of sinus, let me show in the soft tissue picture. See in the soft tissue window, this hyperdensities of fungals and the eosinophilic material everywhere. See the septum is straight, middle meatus wide on either side. Ethmoidectomy is very well done, you can see, and the frontal outflow drainage is white. Yet patient has massive fungal disease. Look at the fungal disease in the frontal everywhere. So now the goal of treatment again is the same, like what has been planned in the beginning. You have to remove this antigen and give wide openings for the future topical steroid douching. Wide openings we can already see existing. When we remove this fungal, we'll again ensure that the wide openings are maintained. If not, somewhere we have to do something. Widen the openings for the surveillance and future steroid douching. But the treatment remains same. Eliminate this fungal antigen, which is fungal, tissue which is acting as an antigen to incite antigen antibody reaction. So completely remove all this fungus from the paranasal sinuses by means of sinus surgery, which we are going to start very soon. It is first, and then we'll follow judiciously with the post-operative treatment. For that, number one is steroid. Initially oral steroid to curb the severe inflammation for couple of weeks, and along with that, the topical steroid for sometimes lifelong. Topical steroids are much safer. The same steroid which is needed to the mucosa can be pushed by the topical means without the need of systemic, because this is a sinonasal disease. You can push the topical steroid in the depth of the paranasal sinus mucosa, yet without systemic side effect, because they have hardly any systemic absorption, avoiding the need of oral steroid. So for that you need to make wide, big sinus openings, mega antrostomies, to ensure that your topical steroid reaches everywhere. So this is how one can think of, planning treatments of such patients. But this is a different endotype. You have to, treat these patients effectively. They need long-term, probably lifetime follow-up and topical steroid douching. In surgery, specifically, you have to ensure mega antrostomies to ensure your topical reaching everywhere. No role of antifungal as such in this particular entity. This is purely non-invasive fungus. This is purely type 1 hypersensitivity, and purely there is no need of any systemic antifungals in this particular patient.
So what are the surgical, what's the surgical plan now?
So surgical plan is full house fest. Whatever remaining work after the previous surgery is left, we have to finish it off. What you can see on CT scan is huge fungal densities. See this big fungal material, and you will see this insipid material composed of degenerated eosinophils and the material. So we have to remove, flush out everything, give wide opening and start topical sinus douching with the steroids. That's the goal. That's the treatment.
So given that it's a bilateral extensive involvement of the frontal sinus, any thoughts on considering a draft 3 modified endoscopic load?
Draft 3 is required when at the end of surgery you find that your openings, what you have given, are not adequate enough to push the steroids inside. Look at the frontal sinus opening. Look at the frontal sinus. This is not a small frontal sinus. The beak is not prominent. Beak is not prominent. There is huge space, anteroposterior distance of the frontal sinus. So there is, I don't think this patient, particular patient requires any sort of draft procedure. Draft procedure is required when this frontal sinus drainage pathway is compromised because of the prominent beak. Because draft involves drilling and drilling of the beak to open up the space. So in this particular case, the beak is not giving any problem. So particularly, what I believe most likely in this particular case, the draft is not required.
Okay, so good, thank you. And would you think that there will be adequate access for douching post-operatively?
Yeah, so the whole goal is for the access of topical steroids, removal of fungal antigen and introduction of steroids. In nutshell, these are the two things which are required for such patients.
Thank you. And also the sphenoid looks quite involved as well, isn't it?
In the previous fresh fest, the fresh fest that we did, what we did for the frontal sinus, can that be classified as draft 1? Because we drilled frontal sinus.
No, widen the frontal sinus ostium. So that is draft 1. Hello? Ready? अच्छा वो केस मेरे वाले ले ले है ना वो फर्स्ट मामूल चालू कर दे फर्स्ट टेम्पनो एडेनोटॉन्स जो भी है
फर्स्ट यहाँ ले रहा हूँ एक बार आया
टेम्पनो एडेनोटॉन्स फर्स्ट हेलो हेलो
Hello, Dr. Satish.
Yes, sir. Can you hear me?
Yes, we can hear you very well.
Okay. So let me show you the first endoscopic picture without decongestion. See the picture of polyposis. See
Yes.
the allergic picture and see the fungal mucin. Can you see?
Yes, yeah.
On the left side. On the right side, same allergic congested mucosa. Sinuses are wide open, but see superiorly towards the frontal. It is blocked and allergic mucin. Can you see?
Yes, yeah.
So I told you, even if you operate, if you do a good job and patients are not followed with the proper medical treatment, see, in such generalized sinus disease like allergic fungal sinusitis, the cause is medical, the core treatment is medical, role of surgery is just limited to remove the fungal antigen and at the same time giving wide openings to allow the topical steroid to go inside. Now, surgery is not the end treatment of this disease. Surgery facilitates the medical treatment by allowing the topical steroid to go inside the paranasal sinuses. This is the role of the surgery. It's not that you operate and forget about it. You can operate 100 times, it is going to come back. So the core treatment is medical and you have to convince, you have to counsel your patient to follow with the medical treatment in such diseases for life. Surgery is the beginning of the better medical treatment that can avoid the need of oral steroid where it makes the topical steroid penetrable. So it has to be very clear to the surgeons, to the clinicians as well as the patient that surgery is the beginning of treatment which facilitates the medical treatment. So I am decongesting the mucosa right now. Hello.
Hello.
See, this is the primary picture after initial decongestion. To open up the nasal airway, nasal passage. See this?
So interesting, isn't it, Dr. Satish, that he seemed to have very similar surgery on both sides, and you can see the difference in the status of the sinuses.
We saw the adequate bone work done on CT scan.
Yes.
This is
so
mucosal
left side
disease.
and the right side.
See now?
Yeah.
This is all edematous mucosa. All see this edematous mucosa which needs medical treatment. Widening the sinus axis further. See, unaerated sinus because of edematous mucosa.
Again, a question very commonly asked in the workshop and meetings. is how wide would you make this middle
Depending
lateral
upon the
antrostomy?
pathology. It always depends upon the underlying pathology. Like in previous case, the maxillary sinus had hardly any disease and we didn't widen it much and it was not needed. In this case, this is a generalized sinonasal disease, allergic. This requires long-term topical steroids.
Yes.
And this required wide antrostomies. This is different pathology.
So you'd be going really wide on this.
See this, wide and see. Look at. So here I am, see, converting suction. Knee cartridge. See, giving wide antrostomies.
What are you considering modified endoscopic medial maxillectomy?
See this, all polyposis because of the ongoing inflammation. See this fungal antigen?
Yes.
See, the bone work is adequate, looking adequate. See the maxillary sinus? All this edematous mucosa will come back to normal once the ventilation and drainage is established and once the topical steroid start reaching to the inflamed mucosa. See this? This is the lamina papracia, the lateral limit. All this is bad mucosa, badly inflamed mucosa because of long-standing inflammation. That's why such patients should be thoroughly counseled for the post-operative treatment. See this?
Yes.
Use fungal material. Still I am with 0 degree. And see, because of the excessive inflammation, this little bit of the bleeding is likely. See this fungal? Classical mucin of AFRS. You discuss about the need of the draft. Let me show you the final frontal sinus work we give and then we'll reassess. Hydrodebrate laga. See this? Why? See, no bone work was required so far. See this? All mucosal
Yes.
disease. All mucosal disease. Just back for a while and take 70 degrees. All mucosal disease. This is completely inflamed because of severe allergic fungal rhinosinusitis. Get it back over there. Oh, 70.
So for the viewers who have joined late today, we are with Dr. Satish Jain in Jaipur, India. After having seen surgeries from Columbus, Ohio with Prof. Kara and Prof. Daniel Prevedelo, then in Sydney with Professor Richard Harvey, we have joined Dr. Satish Jain. He has performed some of the wonderful surgeries with extensive JNA in a child, followed by endoscopic sinus surgery, a very novel, new, refined technique of endoscopic microderivador plus the ablation-based adenoidectomy. And now we are on this case with allergic fungal rhinosinusitis, previous surgery. So it's a revision surgery. So Dr. Satish is taking us to how you clear the debris and get through your sinuses. Hello, Dr. Satish.
Yes, sir.
So we can
you
that
see this fungal material, inspissated fungal material everywhere?
Yes, it's all widespread, very extensive. So we can see that you are finding your way to frontal recess.
Difficult to remove material. Kind of sticky fungal material, difficult to remove.
Yes. Yeah.
This is such an sticky material, which is so difficult to remove. So you have to use various means to push it out, and one of them is irrigation. See this?
Yes.
Irrigation to flush out. Irrigation to flush out. You may use sometimes hydrodebrider, which is a water jet. You can use 360 degree to flush out. See this? This fungus just completely packed the frontal sinus. See this?
Yes. Yeah.
And the goal in this surgery, I told you, is two-pronged. Removing the fungal antigen, and secondly, allowing the steroid to penetrate. That's the goal of surgery.
What do you think in the previous surgery, probably, did they address the frontal? Did you get that feel that they probably had done some frontals draft for 2A or type of frontal sinusotomy?
See this juicing. Juicing allows this to dislodge the fungus in a safest manner.
Dr. Satish, did you get the feel that...
See this huge.
Wow, huge, isn't it? Wow.
So sometimes it becomes so frustrating to remove such huge fungus. It is so sticky, doesn't come out so easily. And you have to do various, use various tactics to remove it.
So, Dr. Satish, can you hear me?
Yes, please.
Yeah. Did you get a feel that in the previous surgery, the surgeon had attempted some type of frontal sinusotomy? Or was it...
No, this patient, I don't think the previous surgeon did any wrong thing. The issue what I see is not following the irrigation. We inquired the patient also that he never followed any douching or anything.
Okay, so they probably have done some type of a frontal drainage procedure.
See this kind of massive fungal disease. See this?
Yeah.
This needs purely steroid dosing. That's it. So this should be very clear. An allergic fungal sinusitis patient, the aim of surgery or the treatment is two-pronged. One is to remove this fungal antigen thoroughly.
Now, with this finding, do you have any sort of reassessment of the plan regarding the frontal opening?
Pardon?
With this finding, with the extensive fungal debris in it, any revision of the plan for frontal?
Draft procedure?
Draft procedure, yeah?
I don't think. See, the opening is adequate.
Okay, so just enough to wash it out.
Yeah, see the problem this patient was, even if you do this surgery 100 times and don't follow with the medical treatment with diseases, this is a medical disease. Goal of surgery is to remove the fungal antigen and wide openings for the topical steroid. If you don't follow with the topical steroid treatment, there is no point in operating. So role of surgery is very clear and role of medical treatment is very clear. Wherever the access is not adequate, suppose, for the topical to reach frontal sinus, to remove the fungal disease, then you remove the beak. That is draft. In this case, beak is not posing any problem. There is no question of draft.
Okay.
Draft is nothing additional but just beak removal. See, this is pure wash. So now I am using the hydro debrider to wash thoroughly. Wash thoroughly with a pressure jet so that you can remove this fungal antigen. See this? You have an adequate frontal sinus opening. Can you see?
Yes. Yeah. See very clearly. So that's interesting. So is that a hydro debrider?
Pardon?
Can you tell us more about the hydro debrider? It looks interesting. Not very commonly
this
used.
is good. To dislodge the, to dislodge the fungus, see this? With the pressure jet. This fungus is so embedded within the pockets of this edematous mucosa. It becomes so difficult to dislodge this. So you have to keep trimming the mucosa, keep decongesting, and keep douching through the mucosal fold to dislodge the fungus. See this? Fungus is dislodged. See with the douching? Dislodged.
Yes.
Like this. See the big chunk is coming out. Big chunk. See the frontal sinus now? Debrider. See the huge opening of the frontal sinus. See the intersinus septum thinned out, eroded because of the pressure. Big chunk came out. Suction. Reverse. See now the sinus much better?
Yes. Yeah. Just clear. Wide access.
All you need to do is sometimes you miss the fungus in the folds of the edematous mucosa. tightly packed fungus everywhere. This is opposite side. For which will come from the opposite side. See, this side frontal sinus is pretty clear now. See all around the frontal sinus. Can you see? This is opposite side, intersinus septum, for which will come from opposite side. This is the opening in the intersinus septum. See this? More and more irrigation. See, irrigation everywhere. All nooks and corners. See, this sign will, all this mucosa will revert back to normal once this fungus is out and ventilation drainage is established and the topical douching is started, the steroid started. So this is many times a very, very frustrating exercise. इरिगेशन पतला वाला देखो स्टील वाला यार मत इरिटेट किया कर एक बार में सुन लिया कर ये देना यही देना
Hello, Dr. Jain.
Yes, please.
Such presentations quite common in your practice or in the region.
Pardon?
Such presentation, are they quite common in your region?
Yeah, common. We get to see such situations very commonly. That's why in such patients, the proper counseling is key. Tell this patient that your surgery is going to cure you. Surgery is going to facilitate the medical treatment. This surgery will facilitate the fungal antigen removal. Surgery will facilitate the topical steroid introduction. And then you have to follow the medical treatment. If you don't, the surgery has no role. Now going to the opposite side. Rest is in the opposite, sinus. We went through the interseptum. Let's go to the opposite side. I am with the 70 degree only. Yeah. 70 से हूँ मैं. See, just mucosal edema. No bone work is required. See?
Yes, yeah.
निकाल इधर.
The maxillary sinus on this side is pretty clear, isn't it?
Yeah, absolutely clear. Only this. See the fungus up there. The frontal sinus is widened. See this? And it
Yes,
is
it's
adequately, wide. It's not that it
Yes, I
is.
agree with you. There's a reasonably good opening, but it's still non-functional. So
It is adequate work in my opinion. All this patient requires is a
compliance.
yes. Wash. Or a little bit of the fungus is left behind. Rest of the sinus is pretty clear. See this? See the maxillary is clear.
Yes.
All other
pretty
sinus
healthy.
is clear.
Yeah.
So this
Agree.
requires a dedicated douching in a particular manner, in a particular position, lying head back or something, so it reaches everywhere effectively. और थोड़ा covered है क्या? वो है क्या तांबे वाला ना? So I'm using a more curved, suction tip so as to mark. Dislodge this fungus. One 20. Wash. Oh, hydrodebrider. See this almost completely clear?
Yes.
Yes, but still we will, I can see the fungal flag, so I want to use the hydrodebrider thoroughly.
I think for the juniors who are watching this, I think you can
This can
see.
be rotated once This can be rotated. Say this water jet.
Can you show us the whole hydrodebrider? How does it work?
This is water jet. Can be rotated 360 degree.
Dr. Satish, can you show us the whole that hydrodebrider, how it works?
Pardon?
Can you show us that hydrodebrider, how it works? The whole of the hydrodebrider.
This is very useful in these circumstances.
Okay.
Yes. So now, rest of the job will be done by the topical. See, everything is clear. Sinuses are thoroughly cleared off.
Yes.
All that requires. See? So this was basically requiring, see, one particular particle, fungal particle. Hata. Yes. Yeah.
So you're working with the angled endoscope, correct, at the moment?
Yeah. So it is out now. See a little bit of fungus there. Trapped. So frustrating within the mucosal fold. ये नहीं जाएगा. So by and large the job is done except this small particle. पहुंचेगी नहीं वो. The brighter. See how such fungus is frustrating. Trapped.
It's almost everywhere, isn't it?
Up they wash. Section. Little dislodged. Coming out. See this? Hello.
Hello, yes. It's a big
Now it is completely cleared. See how frustrating it was. 0 degree. Now we'll see finally at the posterior sinus, if any, 0. And the job is done. Both frontals are widely open. See this?
Yes.
Again, for allergic fungal sinusitis, straight here. The goal of surgery is limited, 2-prong, removing the fungal antigen and ensuring the wide openings for the future topical irrigation. That's it. Surgery is the beginning of the treatment. It is an antigen-antibody reaction which requires medical treatment, steroid as a principal medicine. See this little bit of the fungus in the sphenoid as well. See, trapped in between the mucosal fold. Can you see?
Yes, yeah, it's all full again.
Section. See the fungus. Wall probe is another good way of dislodging such fungus. That's it. So we have wide opening of all the sinuses. See now?
Yes, yeah.
Including frontal. What all is needed is the topical therapy later on. This surgery has enabled the topical to be effective by means of allowing the topical steroid reaching everywhere. See this?
Yes.
That's all about this surgery. And AFRS again is a medical disease. Remove the fungus and ensure the topical reaching. Any question, Dr. Okade? Because we are approaching 3 o'clock. 5 minutes we can continue discussion, question, answer. This is going to be the last case only. It's 3 p.m. India time.
Okay. Are we doing the CSF leak or that's off the list now?
We'll do, but I think the telecast is not going to go after 3 p.m.
Oh, is it? Okay. Fine. I mean, we're okay from our side, but we'll see how Dinesh is. We are okay from our side. See how your technology team is.
Okay.
So if they're not able to work it, that's fine. But from our side, we're okay. We kept the whole time for you. So let me know. But
sure.
Yes, the question. This is a great case. I mean, you can see how to approach this revision sinus surgical cases in this disease, and sort of following the management principles about providing the wide access to the for the irrigation and topicals. The question is, do you consider any oral steroids? What will be your post-op management?
Pardon?
What is your post-op management for this?
Post-op management for this.
Any oral prednisolone, oral steroids?
Steroid douching. For these patients, see, the mainstay of treatment is steroid. This is antigen-antibody reaction. So initially with this kind of, inflamed mucosa, we'll give for some time oral steroid and antibiotics.
Oral steroids, yeah. Okay.
But we'll taper down the oral steroids and continue with the topical for long. So topical steroid is the key. Key treatment is topical steroid. For long. For long.
Okay, thank you. So let us know. We will be in the studio when if you're able to join for the next case. And in the meantime, we will wait for your message and we'll play some information videos. So thank you to your whole team.
Thank you very much.
Anesthetists, for organizing this.
Thank you. Thank you once again for everybody for bearing with us.
Good.
Thank you.
Thank you.
Thank you.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes. Well, propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour delivery system has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
theatre. Definitely navigation is needed in certain circumstances. As I was saying before, if it's a revision case or if it's a tumour that has destroyed key anatomic landmarks, having navigation is vital. It's a great teaching tool, but again, you have to justify its use. But I think also if you've got some unusual anatomy, or when you're going to be changing that anatomy and it puts other structures at risk, in ENT, the main, or in skull base and rhinology, the main structures we're worried about is the brain and the eye and the carotid artery. And if those structures are unusual, have been changed, or where the pathology puts them at risk, that's when you would certainly use it. When you don't need to use it, if you've got a case where the anatomy is relatively routine, you're not doing a big operation, and well, there's nothing really abnormal or concerning with the surgery, then you could say it's potentially not justified. When I worked in the US, they used it for every single case, and for numerous reasons, one of which was teaching, one of which was medico-legal. In Australia, it's not such the case. In Australia, we tend to need to justify when we use it and why. So that's when I use navigation.
I'd echo Raywin's comments there. There are times when navigation isn't required. So, for example, if I'm a private pilot just exercising my aeroplane on a Sunday morning and I'm just flying around the local area, then I probably won't use it. But that said, even these days, or particularly these days, I can put my mobile phone on the aircraft instrument panel, and for $100 a year, I can get a navigation app on there. And for another maybe $300, I can get a little black box I can put in my airplane that can pick up other aircraft that are squawking, that have a transponder code around me. So that is a massive enhancement to flight safety, even if I'm just doing my Sunday pilot lap of the block. And it means I'm much less likely to hit other aircraft or scare myself by getting closer to them. So even for the low tariff trips, I think navigation is still very useful. And for the high tariff trips, that's when the workload leveling really becomes a game changer. And it means I can spend more time as an airline pilot monitoring the systems or thinking about the destination, as a fighter pilot monitoring the tactical system and making sure that no one's getting the upper hand on me. And in terms of how it affects my assessment of a situation, it just gives me that extra capacity to be able to carry out those more challenging tasks.
My name is Dr. Abib Agbatoba. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid
Spring Global Rhinology Network live surgery 2024. So we had a fantastic 3 days of live surgeries from centers from USA, Professor Rick Kara, Professor Daniel Pravedala, who operated yesterday. Then Professor Manuel Bernal Spreckelsen from Valencia in Spain, Professor Paolo Castelnuovo and Paolo Battaglia, along with Mario Turizenoni from Lake Como Hospital in the University of Insabria, Italy. Then Professor Richard Harvey from Sydney in Australia. We concluded with the grand finale with Dr. Satish Jain in Jaipur in India. And that was fantastic. We're getting great feedback from all over. The delegates have enjoyed all these live surgical events and learnings from it, the real-time scenarios, real-time surgeries. So getting feedback from all around it. Those who have missed it because of the time zone constraints, the recording of this event will be available to watch on our YouTube channel. So subscribe to our Global Rhinology Network YouTube channel and also on our website. So to stay updated about our various events, so we started with live surgeries, but it is not only live surgery. We also do various other type of events with initiatives on research. So we had a topical research symposium recently, which will also be available to watch. Then we also have visits to Center of Excellence, then grand rounds. So various initiatives, literature review, the book reviews. So please stay updated. If you become a member of our GRN Academy, then you will get regular information about our events. So we're really thankful to all the participating surgeons for their support to GRN. They've been supporting right from its foundation. They've taken a lot of efforts to make this happen. All the theater teams, the technology teams that have worked tirelessly behind the screen to all this to come together. Again, our big thanks to our GRN studio technology team, Dinesh, Manish, and Anil. They have done a fantastic work. They worked tirelessly through the night and many days beforehand, testing various centers and provided an excellent audiovisual quality. So thank you to the team. Then thank you to our manager who has worked behind the scenes with collaborating with everybody and getting this event through. That's Pam Morer. So thank you to Pam. And also mainly to my co-hosts, Claire Hopkins, Professor Claire Hopkins from University College, King's College London. And she's a clinician at Guy's, researcher, academician. And she was the first time hosted on GRN. Then Dr. Puya Degani from Italy. Louise have been a regular on our GRN events. So all of them have given their personal time to contribute to their this academic endeavor. So thank you to all of them. And big thank you to all of you, all the delegates from around the world, from many 100+ countries. You have logged in at your whenever it's possible. It was a working days. So despite that, you have taken efforts to join us and get benefited from these live surgical events. So thank you once more again. And soon we'll be back with our next event. So stay updated. Thank you. And most importantly, not to forget our supporters, Medtronic and Karl Storz. So they have always have passion to get involved into academics at a very early age, and they are supporting the endeavors and investing into teaching and training. That is great to see, and that's what makes these events possible. So thank you, and see you until our next event.